delegates, and faculty members, I, Lipi Goyal, welcome you all to FeFCon 2022, the 5th Annual National Conference of Fever Foundation of India. Now that I have welcomed you all informally, I would like to invite a senior gentleman over here. I humbly request and invite Mr. Jairaj Ji, the Organizing Secretary of FeFCon 2022, for his opening remarks.
Good evening, all. It's indeed a great pleasure to be here, welcoming you all to FeFCon 22, an academic mega event on various aspects of the most common symptom, fever. FeFCon is growing in stature year after year. From its inception in 2018 with mere 300 attendees, it's heartening to see that the fifth version, the FeFCon 22 now, has more than 35,000 registrations from across the globe. It's an outcome of relentless labor of love from the exalted advisory board, members of Fever Foundation, and the organizing committee of FeFCon 22, mentored by the most respected Dr. Maya, doyen of medicine, and Dr. Muruganathan of international repute, and the dynamic team spearheaded by Dr. Ravindra, Dr. Jagdish Chinnappa, and Dr. Sudarshan, and Dr. Manjula and her team. What you are going to be immersed in the coming 2 days are the distilled wisdom and knowledge by 70 eminent speakers from across the country. You will also witness the brilliant young minds in medicine and pediatrics in the All India finals of PG quiz competition. We also have another academic feast of an antibiotic stewardship workshop that will also be pro-con debate, case presentation, and panel discussions. With this, I would like to hand over the proceedings to Dr. Manjula to take this forward. Once again, a warm welcome to all.
Thank you so much, Mr. Jairaj, for welcoming us all. Now, moving ahead, I would like to invite Dr. Manjula, the convener of Fever Foundation of India, to please take us through the journey of Fever Foundation of India.
Thank you very much. Good evening, everyone. It gives me immense pleasure to welcome you all to this 5th edition of FeFCon. It's really, we are all thankful to you for having made it such a kind of big numbers who have registered in. Just briefly, I am going to run through what happened in this last 5 years, how the journey started with the Fever Foundation, and how we are here today. I'm Dr. Manjula. I am the convener of Fever Foundation. So Fever Foundation has started with a very important vision of striving towards imparting knowledge on the unmet needs and provide information on research, education, and therapy updates on fever management. So what is Fever Foundation? It is an independent, non-commercial foundation which is supporting the educational and academic activity, basically to address the unmet needs in the fever management. As you all know, fever is a very, very common symptom. So we want to involve into a lot of educational, academic activities in the management of fever. The foundation is committed to conceive, build, and sustain programs, as well as to make a scientific initiative which are aimed at providing evidence-based update to the healthcare professionals. So various activities of Fever Foundation can be put under the following categories. We conduct annual fever conference. This time we are on the 5th edition of this conference, and conduct fever CMEs, both for postgraduates as well as family physicians and the practicing doctors, pediatricians, and physicians. We bring about books on fever management and clinical and epidemiological research, challenging case presentation competition for postgraduates, young scholar awards, and also we are involved into a lot of awareness program, patient education, paramedical education, parent education, and public awareness activities. With regard to Fever Foundation FeFCon, we started this FeFCon conference in the year 2018. What was our first annual fever conference, where we had more than 300 delegates, both physician and pediatrician, attended this conference, which was a physical meeting of 2 days conference. Then we had second year, FeFCon 2019, we had more than 500 delegates, physician and pediatrician across India attended this 2 days conference. In 2020, We all know it was the COVID year, so we went into virtual mode. We had 3 days of virtual conference. We had more than 42 speakers, and we had more than 10,000 registration. It was accredited by credit hours by Karnataka Medical Council. In 2021, we had another big event that was also virtual. We had more than 36 plus delegates last year registered for FeFCon. We had the speakers of national and the international repute. And the first time last year, we had poster presentation competition for postgraduates, which we continued this year also. We had a very reputed speakers last year. The keynote address was given by none other than Chief of American College of Physician Darlene Miner, and we had the GC Surana oration by Dr. Muruganathan sir. Then Dr. Arora came in to talk about COVID 19 vaccination. We had the Likewise program last year. And also we had a parent education program, Fun with Fever. So we have also told you brought about 7 books and which is available to you on the platform. You can go to the library on the platform. You can download these 7 books which are brought about by Fever Foundation. And these are all helpful to you in your day-to-day practice. There are books for pediatrician and books for physician. There's one exclusive book on COVID. With regard to fever CME, we have done more than 75 CME. We have collaborated with several medical associations. We have covered more than 10,000 doctors in this fever CME activities. Now we are here today for the 5th edition of Fever Foundation Conference, which is a virtual conference. And the theme of this conference is Fever, Look, Analyze and Manage. It will be 2 days conference, 5th today evenings, and tomorrow it will be for morning till 2:30 in the afternoon. The highlights of FEFCon 2021, I'm happy to share with you that we have more than 40,000 delegates who have registered for this conference, and the number is still increasing. And we have the delegates who are registered, both national and the international delegates. We have both national and the international repute speakers with us. Very renowned speakers are going to speak in these 2 days of scientific event. And this conference is also accredited with Karnataka Medical Council with credit hours. And this time we have also 2 dedicated hall, physician and pediatrician hall. Day one, you will be having the common hall. All the sessions will be in the one hall. Both the common session will be happening. Tomorrow, post breakfast session, it will be in a separate hall. There will be parallel program happening, sessions happening, one in physician hall for physicians and the pediatrician hall for pediatricians. And tomorrow morning, we have a very popular session, which is workshop session, which is antibiotic stewardship workshop. Tomorrow morning, between 9 and 10, 10 onwards, the regular conference happens in the 2 hall. And we just finished a national PG quiz competition, both in internal medicine and the pediatrics. And we also finished poster presentation combination competition for internal medicine as well as pediatric postgraduate students. So just a bird's eye view of how this program is scientific event for FEFCon 2022. Day one, Saturday, which is today, we finished PG competitions, quiz competition between 2 and 4. Now we are here from 5:30 onwards for the common hall where the sessions will be, the topics have chosen such a way that it will be helpful to both pediatricians and physician, intensivist, and all the people who are managing fever, which includes family physician, general practitioner. So the common topics have been taken. And tomorrow morning we have workshop, antibiotic stewardship workshop between 9 and 10, which is also a common session for physician, pediatrician, and all the doctors. From 10 o'clock onwards, there will be 2 halls for physician hall and the pediatrician hall, which is hall A and hall B, where the parallel sessions will be going on. Physician hall will have the sessions of internal medicine, and pediatricians will have the sessions relevant to pediatricians. So this is in a nutshell about how the fever concern, how we have journeyed so far. Once again, I thank you very much for having joining into this event of 5th edition of FEFCon. And before I close, my task will be incomplete if I don't thank these our scientific board, our advisory board members who have been with us, helping us, guiding us, in fact, hand holding us to run this Fever Foundation foundation, all the activities, and helping us in all the scientific academic events, and I am really thankful to them. Without them, we would not have been come so far in our journey. Thank you, each one of you, the eminent doctors who are our advisory board members who are helping us to run this Fever Foundation non-academic scientific body. Thank you so much, sir. And lastly, I welcome you all once again and enjoy the 2 days of scientific fiesta, I can say. And I'm sure you will have really wonderful session and which will help you in your day-to-day practice. Thank you so much. So now to begin the session, I request our mentor, Dr. Maya sir, to give us the welcome address. Although Dr. Maya sir does not require any introduction, it's my proud and privilege to just say a few words. It's as a formality. All of you know Dr. M. Maya. Sir is MBBS and double FRCP. He is the chief patron of Fever Foundation of India, former professor of medicine, Karnataka Medical Council. He's a senior physician currently at Rangadhara Memorial Hospital. He's graduated from Mysore Medical College, did his fellowship in Royal College of Physicians, London and Edinburgh and Glasgow. And he has been in the teaching faculty in almost all the government colleges, Hubli, Bellary and Bangalore Medical College as a professor more than 2 decades. After retirement, he has been doing a lot of teaching work, educational work, and that too he has taken a voluntary retirement and started his very famous Maya Multispeciality Hospital. He is in the private institute for more than 35 years, and he has been the president and vice president of almost all the medical association IAP, and also he started a medical education and research trust for the past 40 years where it is involved in training the postgraduate student across the India. They come and to get trained and go. And sir has been distinguished award winners for several awards including API, Infosys, and Doctors of Science from Rajiv Gandhi Health University, and he is the Best Teacher Award in 2019. So he's something like a Pitamaha for all the doctors, and he's been guiding everyone in their practice and the clinical medicine. Dr. Maya, sir, and we are thankful to have you as our mentor. May I now request you to kindly give the welcome address of FEFCon 2022. Over to Maya, sir.
My dear delegates, speakers, and invitees, on behalf of the Fever Foundation, I have got great pleasure in welcoming you all. I am very sure that the sessions will be very successful. On fever. Fever, as Sir William Osler said in 1849, humanity has three great enemies: fever, famine, and wars. Of these, by far the greatest and most terrible is fever. Fever is a host defense response to infection, both emerging and re-emerging, and inflammation, drug reaction, neoplasm, autoimmune disorders, and vascular disorders. It's a common manifestation of many diseases, but surprisingly, so uncommonly, the fever is discussed compared to ischemic heart disease, hypertension, diabetes mellitus, with scientific studies with many scientific studies. The fever manifestation in diseases seen in all countries, in all age groups. These patients are usually initially seen by general practitioners or family physician. Even fever is recognized by the patient himself. However, doctors feel there is a lack of discussions and academic sessions regarding diagnosis and management of fever. Hence, some committed doctors formed an educational trust known as Fever Foundation in 2018, one at all India level and several at states levels. The Fever Foundation addresses the unmet needs in fever diagnosis and management. The response from the doctors is overwhelming.
Thank you very much, Maya sir, for giving a wonderful welcome address and then guiding us to run through it. Now we begin the first scientific session. The first session is a review of pox virus, emergence of monkeypox by Dr. Suresh Kumar. I have the privilege of welcoming our chairperson, Dr. Shankar sir, to this. May I now request Dr. Shankar sir to take over the proceedings. Dr. Shankar, sir, is MD, General Medicine, NIMS, FICP, and FISEM. He is a professor of General Medicine and Superintendent and HOD of Sir Ronald Laws Institute of Tropical and Communicable Disease, Hyderabad. It is very commonly and very famously known as Fever Institute across Hyderabad and across India, even globally. Academic Senate member, Kaloji Narayan Rao, University of Health Sciences, Telangana. He's been the past special officer, additional DME office at Hyderabad, past director of Institute of Preventive Medicine at Hyderabad, and past executive committee member of Medical Council of India. Sir also has been very, very helpful to us in conducting all the academic session under Fever Foundation. Over to you, Dr. Shankar, sir. Kindly conduct the proceedings, sir.
Yeah. Good morning, all, and I'll privileged to introduce our a friend and senior colleague, Dr. C. Suresh Kumar. Audible? Am I audible, Manjula?
Yes, sir. You are audible.
Yeah, D. Suresh Kumar is a senior physician and is a American certified tropical medicine fellowship in HIV and AIDS medicine. And he was co-founder, best of MD, that is doctor's director, the senior consultant infectious diseases physician, Apollo Hospital, Chennai, and advisory board member of Fever Foundation of India. And he's a young investigator award from the International AIDS Society 2007, and is International Infectious Diseases Fellowship Award from American Society of Microbiology 2010, and he has best international research paper on HIV/AIDS from Infectious Diseases Society of America in 2011, and he the first prize from API for Dr. J.C. Patel and B.C. Mehta Best Paper Award under the category of original article in 2013 for the article that is melioidosis in emergency infections in India, and is a professor. Also, he has got a oration, a Professor S.K. Rajan Gold Medal Oration Award in T.FCon 2015. Now, I welcome Dr. Suresh Kumar to talk on the monkeypox.
Yeah, so I sincerely thanks the Fever Foundations for giving me this wonderful opportunity to open the innings of 5th FeFCon 2022. And I sincerely thank my chairperson for the kind words of introduction. So we are sticking on the time. I am also going to try to stick to my time. If I overshoot my time, please stop me when the time overshoots. So, okay. I think I'm audible. Yes, please. Yeah, good. Okay. So today I'm going to discuss about the pox virus. Right now, everybody knows a lot of viruses are emerging and re-emerging. What is more important? What is more important? We need to know the principles. We need to know the principles of infections, because infections is one of the commonest cause for the fever. If you apply this principle for any infections, you can tackle any infections. So the re-emerging of the pox virus, my focus is towards monkeypox. But despite monkeypox, I'm going to give how you should approach your infections, how you should approach your fever in your practice. That's what I'm going to do in next 20 minutes. Before that, my disclosures, we are dealing with a lot of things like chickenpox, bird flu, swine flu, mad cow disease, monkeypox now. So people wondering whether I'm a veterinary doctor or a physician there. We are infectious disease doctors. We are physicians only. Don't worry, I'm not a veterinary doctor. We send a lot of cultures. And we react to the cultures in sensitive way according to the sensitive report. So we call ID physicians. So my objective today, when to suspect monkeypox in your practice, or when to suspect any infections in your practice, how to confirm and manage the disease, can we prevent? And I'll try to summarize. We know COVID has shown a lot of infections emerging and re-emerging, and we need to be fully aware about the diseases. If you are not aware about the diseases, you are going to suffer. I'll show how we have suffered and how we are going to suffer in the future also. So I'll show a couple of pictures here. Can anyone tell? Please, the participants can go ahead and vote. Which is monkeypox rash? First person got extensive travel within India and presented to me this rash. Second person is a men having sex with men, presented with the rash in the genital regions. Third is a young lady. Her husband used to travel, but she's staying in a home. She presented with some rashes. If you are able to see some rashes on the face, yes. Fourth person is a healthcare vessel. He was working as a laundryman. He handled the hospital laundry and carries the hospital laundry on his neck pad. So this is a recency presented with me, no fever. And this man is a person from rural part of Tamil Nadu, traveled to Nigeria, stayed in the Nigerian ship. He's basically a shipman. He was working in the ship for 3 months. Unfortunately, the ship got stuck because of the bad weather in Nigerian shore for 25 days, 30 days. Then when the ship started moving to the US, he started developing fever, rash, vomiting, landed with rash in the US, came back by flight to India with the rash presentations. So anyone say which rash has got monkeypox rash? Please go ahead and vote. 1, 2, 3, 4, 5. Which is your choice? in the chat column so that we can have the discussions. I think Dr. Manjula might help the last, whether the persons who answered which questions. I thought of doing poll, but unfortunately the polling was not possible today. Probably tomorrow morning we got a sessions. I run the poll tomorrow morning. So meantime, Dr. Manjula will help me out this one. Okay, sure. So this is a case I just now discussed. 40-year-old male, no comorbid. He came in May 2022. That time monkeypox alarm was there in India. So rash present 7 days durations. This is a classic rash. Initially some fever, feverish feeling. Past medical history, nothing. Travel extensively and is well-to-do person. In fact, his friends only suggested, looks like monkeypox, go and consult a physician. Why are you not consulting a doctor? This is monkeypox. People are talking about monkeypox in the social media. That is why he came and met me. What will you do now? Yes, this is the first case of monkeypox in India. That time, no case has been reported in India. This is early part of May, remember. No risk factors. He's not travel outside India. Maybe in medicine, nothing is black and white. Always all is gray. I need monkeypox PCR. That point of time, PCR was just getting into India and NIV just started doing a couple of cases only. Give some antiviral topical creams like remdesivir or something people used to give for COVID. Other some antiviral you can give and escape with it. So when to suspect monkeypox? The monkeypox has got characteristic rash. The rash is got either papules or macule or vesicle. All forms can be there, but all are monomorphic, not like your chickenpox. Chickenpox has got pleomorphic rash, but monkeypox has got monomorphic rash. One side, all will be same, then start moving around. Then how it start moving around? Centrifugal way. That means starting on the face, going down. That's called centrifugal. Chickenpox has got centripetal, starting in the trunk goes up. That's called centripetal. And chickenpox has got all pleomorphic rash. It's not monomorphic rash. So this is what we need to know, and we need to have epidemiological criteria. Whether the person has got contact, the person has got travel. Always in infectious diseases, we need to take proper history. If you take proper history, 90% of the problem has been solved. We need to know what you did, where you travel, what you ate, what medications you are taking. So this is a basic mantra. Writing medicines is easy, but making a diagnosis, we need to spend some time in history taking as well as spend some time in the physical examinations. So what we need to do, that point of time, what are all the areas has been reporting? Usually it is happening in Africa, but this episode happened mostly in the Western world, Europe, as well as it is mostly reported in the US. So it's more common. Afterwards, almost 70 to 75 countries were affected till today. Almost 76,000 cases has been happened. 538 deaths happened so far with monkeypox. So it's spread across almost all the continent. Almost 75 to 80 countries has been affected with the monkeypox. But during the time of May 2022, it is mostly in Europe, particularly in UK, as well as in US, it's quite common. Spain has got another outbreak at that point of time. So we need to know what test to diagnose it. Ideally viral culture, but viral culture will take time. Availability is lacking. So nowadays we're using PCR techniques. PCR is just check the genome. During the time of COVID, everybody aware. PCR means what is it? COVID PCR, even nook and corner people started talking about PCRs. So with the advent of PCR, PCR is just see the genetic material or the virus present in the body or not. What symptom is common? Fever, but not always present. Rash is characteristic feature. The rash should be generalized distributions in the rash. So this is before 2020-22. This is a classic presentations of monkeypox. People from Africa, particularly children, not vaccinated, diffuse rash, along with some epidemiological contact. If you are able to demonstrate either the virus or by the PCR, you can make a diagnosis with the centrifugal distributions, monomorphic lesions. But what happened? Rash should be there. Some systemic symptoms, fever, rash, joint pain, along with some lymph node. We can think about it. To confirm, we need to have some specific PCR. But what happened? This is a second case I shown just now. He's a 23-year-old male from South India, from Nellore. We got a lot of cases from Nellore, Tirupati, and Chittur belt. He's basically men having sex with men. He got rash in the genital regions. But why he came to me? Not because of the rash. He was tested for HIV. That HIV was weakly reactive. He was worried about HIV is positive or not. He's not bothered about the rash. That is why he came to me and landed with this rash. Whether I am HIV positive or not, he's not bothered about the rash. But the referring physician asked me to check whether the person has got monkeypox or not, because this is also happened during the month of May 2022. So I'll go and ask the participants, does this patient have monkeypox? Yes, this rash has got characteristic. It involved the genital region. He got a risk factor, men having sex with men. Even HIV is doubtfully positive. Men having sex with men rash. Yes, I need to think about it. No, I need to have PCR. I can clinically suspect, but I need PCR. Or start targeting the HIV. He came for HIV. Why you bother about monkeypox? Leave the monkeypox, treat the HIV. So what do you think about it? So please go ahead and vote so that we can have discussions towards my end of my talk. So this is another NEJM publications. This is a lesions published in NEJM. Almost similar presentations what I encountered in NEJM case report. Almost similar rash, involvement of the genitals. So this is a characteristic rash. So what happened in monkeypox in 2022? What descriptions I made just now? Children, African, centrifugal distributions, monomorphic, prodrome symptoms. In 2022, the chances of fever, generalized rash, monomorphic rash, everything is less common. In fact, fever is present hardly 50 to 60% of the cases. Fever is not a classic symptom. Rash is characteristic symptom, but what is missing in the rash? It is not centrifugal. It is mostly genital region or oral or perioral region or intraoral region. It is called more common. And mostly the lesions are vesicular or pleomorphic also presentations. So this is a description of first 7 cases in UK and subsequent US cases. I shown the data here. So this time it is not generalized. It is only localized in the form of genital region, oral region, men having with sex with men, not children. It's moved to adult populations, men having sex with men, and it's more of genital lesions and it's pleomorphic rash. And prodromal symptom like fever is missing, but lymphadenopathy was present. So we need to know why we need to know. We need to know to make a diagnosis. So how you update the thing? Attend FeFCon every year 2022. We are giving a update for you. So it's easy for you without reading your books. You can update your knowledge by attending regular conferences. You can able to update, or you need to follow some of the good portals where we can teach a lot of materials for you people. So this year it is distributed to the general populations, not only to the African populations. US, UK, well-developed countries, it moved. And almost all the continents, all the countries, almost 75 to 80 countries has been reported. So we need to think. So don't think it is African problem. This is children problem, centrifugal distributions. You need to keep your eyes broad. That's what we need to do. Then only we can make a diagnosis of it. So this time the lesions are few. The lesions are painful, oral, anal, and rectal lesions. That is most characteristic of lesions, not generalized lesions. And similarly, the symptoms like fever, prodromal symptoms is missing. Joint pain and lymphadenopathy present, but not always. So think about it. These are all the characteristic symptoms, but this time the lesions are not present always. So we need to think about it. These are all the common places of the rash. So we need to know vesiculopustular rash is more common compared to pleomorphic rash. So what happened to the epidemiology? Sometimes the lesions looks like cancer also. Nasal necrosis is skin lesions. People think of mucormycosis, anything black, or people think of angio-invasive diseases. But this is one of the patients with HIV. And patients with HIV don't expect typical features. The presence of HIV, the presentations may be varied. The presentation may be varied. The presentation may not be typical. That's what underlying. So what happened to 2022 monkeypox? From children, it moved to the adult. From African country, moved to the developed world. Instead of generalized rash, it moves to localized lesions. Instead of prodromal symptom, without prodromal symptom. So what is classically an African disease? Now it's a generalized disease. So we need to update. Unless we update, these things won't be happen. So we need to know the syndromic approach. What is the syndrome now for monkeypox in 2022? Young male, particularly people having men having sex with men from developed world, presenting with the genital lesions, oral lesions, vesiculopustular, may be associated with the fever, associated with the lymphadenopathy. You need to make a clinical diagnosis of monkeypox in your practice. That's what we need to do. It moved from children to adult, moved from black to white. That's the thing. So the dictum in infectious disease make a syndrome. What is a syndrome for monkeypox? Fever, skin rash, that too in the genital regions, in a men having sex with men without much prodromal symptom, think of monkeypox. But other syndrome like fever, headache, confusions, meningitis syndrome. Fever, cough, shortness of breath, pneumonia syndrome. Fever, dysuria, urgency, urinary tract syndrome. Fever, abdominal distension. You think about gastroenteritis or intra-abdominal sepsis. So this is how first dictum syndrome. We always copy from sexually transmitted disease physician. They make genital ulcer syndrome, genital discharge syndrome, lymph node syndrome, they make it. So make a syndromic approach in any of the diseases. So I'm telling, apply this principle for your future infectious diseases, what you are encountering. Rash, ulcer, anorectal pain, fever, lymphadenopathy, Men having sex with men, young male. Think about monkeypox. This is another case what I shown initially. 29 male handling hospital laundry. Rash is present. I told there is no prodromal symptom, no fever, no body pain, nothing. He got simply rash and he's handling the hospital laundry. Whether the hospital admitted some monkeypox case, we do not know. He is not married, denies sexual exposures, no travel. HIV is also negative. Papular lesions, sorry, the wrong spell, papular lesions and itchy lesions present. So how many participants want to know this patient has got monkeypox? Yes, he is handling hospital laundry, particularly he is carrying the laundry here. No cases reported in India at that point of time. Again, May 2022, maybe we do not know. The patient has got young male, rash, working in a hospital, carrying hospital laundry. Please test or refer to dermatologist. What are you going to do now? Please go ahead and vote so that we can have discussions at the end. So we need to know about the virus. The virus is a DNA virus. What is the differences between the DNA and RNA? RNA viruses can replicate. They are error prone. That means mutations are very high. DNA viruses copy the genetic material near normal. So the chances of mutations are very rare. And these are all the list of pox viruses: cowpox, monkeypox, vaccinia, and variola. But this is a DNA virus. It is an enveloped virus. What is the meaning of envelope? Easy to kill the virus with soap and water. Whether to kill the virus with soap and water is possible. So there is no specific better cleaning agent. Ordinary soap and water is more than enough for cleaning the patient's rooms or inpatient's room. So we need to know what is the route of transmission. That is the point here. The patient has got working as the laundry fellow, is taking handling the laundry. Monkey has got no way relation to the pox. In fact, it was initial cases was demonstrated in the monkeys. That's why it got named. Monkey has got no role. It has got no role in the transmission. Don't think monkey is playing a role and killing the monkeys is going to help out. It has got no role. First few cases has been reported in the monkeys. That's why it got monkeypox. This is a characteristic lesions of the monkeypox. So what happened? The numbers gone up. I failed to update the thing, but yesterday I did a trick. Number one, almost 78,000 cases has been reported worldwide now. So monkeypox outbreak is keep growing. Every day it's keep growing up. And lesions also not like typical. This is like a molluscum contagiosum like lesions, typically deep-seated, well circumscribed, vesicle or vesicular pustules with umbilications. So the route of entry is more important. Mostly it enters through the respiratory route, the droplet, or close intimate contact. That's why men having sex with men, close intimate contact, they got affected. Mucosal surfaces, yes. Parenteral bite, scratch, yes. Sexual route, doubtful, but nowadays people are talking about sexual route is also possible, mother to child. Usually because of the close intimate contact, whether sexual contact, but they demonstrated in the semen, initially by PCR method, but half late they demonstrated by semen by doing a viral culture also. So it is also a sexually transmitted diseases. According to them, when you think monkeypox, we need to think about sexually transmitted diseases, rule out HIV. When you think TB, rule out HIV. When you think HIV, rule out TB. So in infectious diseases, certain diseases has got correlations and association. Try to figure out the correlations and associations. And from one person, for example, this person may get it from other person and he can transmit the disease. This is called cycle of transmission. During COVID, we know one person goes outside, get the infections, come back, transmit to the entire family. The family member transmit, keep on growing. Similarly, monkeypox also possible. 5 to 7 generation, he can transmit. One person transmit to other person, other can transmit to other person. The cycle can keep on growing. And we need to know sexually transmitted as possible. They demonstrated by PCR. Of late, they demonstrated by the viral culture also. So monkeypox is basically a sexually transmitted disease. Who is going to get more? Who is going to get vulnerable people? People who are sexually prone, particularly men having sex with men. People who are healthcare workers, like a laundry fellow who's handling the hospital laundry possible. Microbiology doctor, infectious disease doctors, they are all more prone for getting virus infections. So that is why this is a close contact. Family members, household contact, they are sharing the same room. The respiratory droplets is coming up. So we need to know proper history taking, how the source and what is the risk of getting infections. Then we need to know the natural history, how long the person developed. It has got long incubation period. Why the incubation period is important? We can prevent after the exposure also, we can prevent if the incubation period is longer because the virus takes some time to produce disease. Before it produces disease, we can block the disease. That is the nature of incubation period. Then what is the outcome? Patient need to be in isolation for 21 days. For COVID, people are not isolating nowadays. Initially 14 days. Nowadays, ask him to isolate for 5 days. People are not isolating. But for monkeypox, all the lesions should scab out. till the time they need to be in isolations. So the point number 2, know the virus, know the microbe, how it is transmitted, how it is going to affect you. If you know this one, it's very well. If you do not know, so what will happen? This is a number of doctors died during COVID wave 1. So many people lost their life because they do not know how it is transmitted. That is why they suffered. So know the virus, know the route of entry, how to protect the virus, that is more important. This is a dictum infectious disease. The third case, what I shown, this is a young lady, husband travels, but she presents to me there. But if you see, the other half I didn't show. The other half shows clearly normal. So this is one half of the body, and most of the lesions are pleomorphic. So this is varicella infections, chickenpox to this lady. Other part of the body is also affected. So classic description between monkeypox and chickenpox. Monkeypox centrifugal, chickenpox centripetal. That is vesicular on all lesions. It is monomorphic. Nowadays, it's more of genital and monomorphic is possible. Men having sex with men, that is any sex group, any age group can be affected. Measles is not very confusion, but secondary syphilis or other sexually transmitted diseases like molluscum contagiosum in children, not sexually transmitted, but molluscum in children we can confuse with a thing. So we need to know the differential diagnosis. That is more important. When you encounter some symptom, don't make only one diagnosis, make multiple diagnoses. If you think broad, so that we can narrow down what is going on. If you think narrow, it's a bit difficult for you. So how to confirm it? We need to do the PCR. For PCR, what sample we need to do? Either the lesions, you can take the vesicular lesions, or you can draw the blood. How to draw the sample? Break the lesions, take the sample. That is most important lesions, or swab it. Nowadays, like Gene Expert, CBNAT test, PCR also coming up for monkeypox. Point of care. Take the test, do the test within 1 hour, you can get it. They are working on it. Still, it is not out. But most of the time, we need point of care test. That makes easy our job. Turnaround time is less. Transmission risk to the other people will be bit less. So we need to go with point of care test. In summary, we need to know lab. Which lab we need to know? Malaria means PCR, either QBC or peripheral smear. Typhoid blood cultures. Scrub typhus means PCR or clinical diagnosis. Leptospirosis again PCR. Influenza means PCR. So we need to know which test for which diagnosis. That is more infectious disease. Always monkeypox means PCR. The last case is the person went to Nigeria, stayed in the Nigerian ship. Maybe I do not know. You might have sex in the ship. He came with the lesions. This is a classic description of the lesions. Probable monkeypox, but that time I don't have PCR. We need to know the risk stratifications. If the patient has got comorbid conditions or not, severity of disease is not. When the patient severe, more lesions, patient not able to eat, multiple lesions, we need to admit and we need to start medications. The patient has got very few lesions, just observe the patient. For example, COVID, patient has got respiratory distress, treat. Vaccinated, very mild symptom, don't treat. So don't think infectious disease means always we need to treat, but all patients need paracetamol. Maybe your Dolo might help out, not your Ticovri might help out. So we need to know the treatment options, antiviral medications. The best antiviral medication is the Ticovrimat. Right now, it's not available in India. Cidofovir is available in India. Cidofovir is very costly, but effect is not very great. So we need to know what are all the treatment options for the infections you are encountering. So Cidofovir, Ticovrimat, and immunoglobulin. Only Cidofovir is available at this point of time in India. So know what is the best option. Whether I want to use it or without using, I can get away. William Osler told, before write a medication, think two things. Whether the patient should recover from the disease and the medicines what you are prescribing. So always think about unnecessary medications, don't give it to the patients. This is an exposure. The nurse exposed to this person without wearing a proper PPE. People thinking about PPE, whether I need to wear a mask, people keep on asking, COVID is gone. It will protect not only COVID, a lot of exposures can be protected, particularly TB in this part of world. So we need to take certain vaccinations to prevent the disease. What vaccine? BCG. But people always confuse with BCG and smallpox. BCG is a small lesion, elevated one. Smallpox is a bigger one, depressed one. So don't confuse. Smallpox vaccinations give little bit of protections. People are thinking smallpox vaccinations again to protect monkeypox if the outbreak spreads. Fortunately, it has come down. So post-exposure, even after the exposure, the incubation period is longer. You can take vaccines and protect against the disease. That's called post-exposure, particularly for healthcare personnels. A lot of prevention is possible in infectious disease. For example, chickenpox, hepatitis B, meningococcal disease. Even after exposure, you can prevent the disease. Keep in mind. So always the incubation period is going to help you out. So always, yes, monkeypox is also possible. We can able to do it. And we need to know what PPE need to wear. Pre-exposure, yes, before exposure itself, if you are an healthcare personnel, you are going to be exposed to a lot of infection. Take vaccines if you are not taken the vaccinations. So pre-exposure is possible. Two types of vaccine. Right now in India, it's not available. Going to hit soon in 2023. So in summary, monkeypox syndrome, fever, rash, lymphadenopathy, men having sex with men, genital lesions. That is a syndrome. What is a test? DNA test, PCR test is a good test to identify the diagnosis. Differential diagnosis, varicella, secondary syphilis, molluscum, HSV. What test? PCR is a confirmatory test, is a DNA virus. What is a management? Stable patients, few lesions, symptomatic therapy, more lesions, painful lesions. Patient is suffering, we can start ticorimet. Right now, it's not available. So this is how we need to know how to approach infections in your practice. So monkeypox needs more protection, either vaccines or protections not in the form of mask, but in the form of vaccinations. So which lesion is monkeypox? For me, the lesion is herpes zoster. This is genital wart. This is varicella. This is contact dermatitis. And this is monkeypox. Probable because that point of time, I don't have PCR. So think broadly, whatever lesions, don't put your money on monkeypox. COVID is now hungry. You are talking about monkeypox as a number one. 2020 and 2021, we talked about COVID, but now we given importance to monkeypox in 2022. So COVID is hungry with FeFCon team there. So those who want to do infectious disease fellowship, yes, if you completed MD medicine, DNB medicine, feel free to message me. If you want to do infection control, antibiotic stewardship, even if you're a microbiologist, yes, feel free to do it. Best of ID is providing to you. Thanks for the wonderful opportunity. I overshooted 3 minutes. Sorry for the overshooting. Thanks for the chairperson allowing me to overshoot, and happy to take a couple of questions to you.
Yeah, thank you. That's excellent topic and discussion by Suresh Kumar. If any one or two questions, any is possible, we'll allow one or two questions.
Yes, sir. Our next event, can you take the questions from the platform and share it with us?
Yeah. Yes, you can. Otherwise, we can later you can share it. If it's possible, you can ask anybody is ready to ask any one or two questions. We'll allow. Otherwise, you'll go ahead.
Yes, sir.
Wait for a
Don't
minute.
have any question as of now.
Right.
Okay.
I request the delegates to post your questions on the chat box to the speaker, and it will be forwarded to the speaker. Currently, your chat box is enabled, so you can use them to paste your questions.
Okay. Right. We can go.
So there is one question which has come from the 3D platform. What are rapid diagnostic kits which are viable?
Okay. The rapid kits is the rapid kits is the rapid kits is similar to what we do for COVID. Similarly, what we used to do for TB. This is called CB-NAT based test, nucleic acid cartridge based test. They need to take the sample, put it in the cartridge, put it in the same TB machine, expert machine. You put it there, he can have it. So we need to have some same testing kit. They validated the test. It's not out of the market. They're almost in final stage of validation because FDA needs a lot of data. Then only they can clear the product. So they submitted the data for FDA approval. Still, FDA has not given clearance. Soon they're going to give clearance, but they validated the test. It's working well. Even in fact, 2017 they tested, but that point of time, the number of cases are a bit low, so they didn't go for a FDA approval. But now they submitted the papers, probably by 2023, point of care test. This is PCR with the machine, same expert machine what we use for TB, that's going to be available. Right now, it's not there.
Yeah.
May I ask one question?
Yes, sir.
Yeah. Yes, sir.
Suresh, excellent talk. I have some doubt how. What type of cytokine storm monkey pox can cause? Like capillary leak syndrome or DAC or intravascular coagulation or hemorrhage, different types of cytokine storms. See, in COVID, till post-mortem reports from Italy available, we're not aware of it. What type of this? Second question is there any effect of myelin, demyelination, or peripheral center? These two questions I want to.
The second one is easy to say, sir, because all viral infections or any bacterial infections, the demyelination risk is always there. Particularly the Guillain-Barré syndrome, GBS is always there, differential diagnosis, both for infections as well as vaccinations. But so far, my knowledge goes in 2022, there is no GBS has been reported, but all infections can cause GBS because our immune system can react. The first one, cytokine storm with monkeypox. I need to check the data, sir. So far, my knowledge goes there's no major cases reported because mostly it's a genital lesions.
Why is
Sorry, sir.
why
Genital lesions, some voice is not clear.
now it's
Suddenly
okay.
your voice went down, sir. Okay.
I do not know, sir. Maybe poor internet link there. So the second question is easy. All infections can cause demyelinations. Guillain-Barré syndrome, GBS is possible. The first one, my knowledge goes cytokine storm. I need to check the data, sir.
Yeah.
So
As
what
now,
is the cause of mortality then? What is the cause of mortality in monkeypox?
Actually, they cause encephalitis. For example, the Kerala death is because of the encephalitis. Involvement of the brain has caused the lesions, not because of the cytokine storm there. That's only
Then
one case reported from Kerala.
point,
is
point
viral
zero
encephalitis or
two.
demyelinating encephalitis?
Yes, sir.
Is viral encephalitis or parainfection demyelinating?
Viral encephalitis mostly.
Viral, okay.
If there is no questions, Manjula, we'll go next slide. Thank you, Dr.
Thank you,
Suresh.
sir.
Excellent
Thank you,
answers.
sir.
Thank you.
Madam, you have to unmute. Madam, you have to unmute.
Sorry. So thank you very much, Dr. Suresh sir. A wonderful session as usual, and Dr. Shankar sir for conducting so well. Dr. Narasimhalu sir for pitching in with a few questions. Now we move on to the next session, which is hemorrhagic fevers. So I have a pleasure and a privilege to welcome Dr. Balasubramaniam sir, uh, who is the visiting consultant Sri Kanchi Kamakoti Child Trust Hospital, and he has been the former medical director of pediatrics at again the Child Trust Hospital. Sir has been in the teaching and has been helping us also with a lot of academic activity. Sir has been the honorary pediatrician of South Railway Headquarters, also chairperson of IAP Infectious Disease 2022, convener of IAP ACVIP, advisor for IAP ACVIP from 21-22. He's been a distinguished DNB teacher, and he won the award for the same in 2014. Tamil Nadu Dr. MGR University Lifetime Achievement Award, and he has been several index paper, more than 150 index publications to his credit, and more than 40 oration, over 500 session in IAP forum, or 500 PG session, and he's been the IDC Fellowship Coordinator at Kanchi Kamakoti Child Trust Hospital. Areas of interest include pediatric infectious disease, PG teaching, vaccine, and COVID-19. And sir is also helping us with the Fever Foundation, lot of academic activity. Dr. Balasubramaniam sir, it's pleasure and privilege to have you with us, sir. May I now request to kindly take over the proceeding and conduct the session on hemorrhagic fever. Over to you, sir.
Thank you, Dr. Manjula. Thank you, my dear friend, Dr. Jagdish Chinnappa. It's indeed a privilege to be part of this Fever Foundation. I think without wasting much time, we will straight away move into the topic of hemorrhagic fever, which is emerging as a threat, not only to children, but also adults across the world. We have two distinguished speakers, Dr. Chitkara and Dr. Sara. I would hand over to Dr. Manjula for their appropriate introduction. Let us get on with the lectures. Thank you.
Yeah. RX event, can you share the slides, please? Dr. Balasubramaniam sir, can you go ahead and send both the slides would come, sir? Yeah.
The first speaker in this session is my dear friend, Dr. A.J. Chitkara, who is the director and head of the Department of Pediatrics at Max Super Specialty Hospital, Delhi. He's a pediatric ID expert, and he has special interests not only in infectious disease but also in vaccinology. He was the chairperson of our IAP infectious disease chapter in the year 2014. He was also the member of the Indian Academy of Pediatrics vaccination committee in 2002 and 2012. He has several publications, mostly related to vaccines and diseases. He's a very shrewd clinician excellent communicator, and probably the most suitable person to discuss hemorrhagic fevers today. Over to Dr. Chitkara.
So let me share my screen. Sure. So I hope I am audible and my slides are visible. Is that okay?
Yes, please make it full screen.
Yes, sir.
Okay. So we all as pediatricians see lot of cases of fever with different kinds of rash. But what we are going to discuss today are specifically fever with hemorrhagic rash, which may be petechial, purpura, or ecchymosis. Now, when you evaluate a child with exanthem, it is always important that a detailed history and a careful examination and a full examination is done, not to miss the subtle clues which may give you a diagnosis. However, the most important thing is that when you are evaluating a fever with exanthem, it is important to know the local demographic and epidemiological factors, especially exposure to insects, animals, farms, jungles, or whether we are in the midst of an outbreak. And why do I say so? Because in the years to come and the years which have gone by, the most of the fever with exanthems and especially hemorrhagic diseases are the emerging and the re-emerging zoonotic diseases. And I think the future is also of zoonosis. So therefore, a careful evaluation is required. When I evaluate a rash from the onset to the progression to the distribution of rash, invariably gives me a clue to the underlying diagnosis. So therefore, rash, it is always said that skin and eye are almost a window to any of the infectious diseases if you carefully look at them. While most of the hemorrhagic fevers are arboviral infections, flavies or others, and we all are familiar with dengue, chikungunya, other viral hemorrhagic fevers like Congo premium hemorrhagic fever, we have witnessed diverse manifestations of COVID in the last 2 years, and Ebola, which fortunately has not come to India, but we are aware of Ebola, which is again a hemorrhagic fever with a very high mortality. Amongst the bacteria, leptospirosis, rickettsia, and the parasitic malaria are endemic in many of the states or districts in the country. Meningococcemia, you all know, we were almost endemic in North India from 1984 to 2005, but since then it has been only a sporadic case. And the last outbreak which was reported was somewhere in 2010 to 2014 in the Northeast India. There are many causes of a fever with a hemorrhagic rash which are non-infective, and I wish to highlight here what we call as a vasculitis. While invariably they have a subacute presentation or a chronic presentation with a lot of other underlying factors which guide us to the diagnosis. But remember, vasculitis, which is a kind of an end stage organ damage pathogenesis, causes inflammation of the blood vessels. While we attribute vasculitis to most of the non-infective, whether it is a chronic systemic inflammatory disorders or collagen vascular or autoimmune, what is important to note here that all infectious diseases, whether these are bacteria like rickettsia or these are viruses like dengue, CCHF, or chikungunya, the hallmark of a hemorrhagic rash is an underlying vasculitis, which may involve small, medium, or big vessels, damage to the endothelium or damage to the intima. Now, this gets mediated through a cytokine surge and also the involvement of the Janus kinase STAT systems. So, you would be aware that many of the JAK inhibitors are coming into play for many of these cytokine surge seen in the viral infections. While you may have pleomorphic skin rash in vasculitis, but remember, a hemorrhagic rash on the ears is always a pointer towards a vasculitic phenomenon, be it an infection or non-infection. Let's now see a few cases. There are certain clearly recognizable viral hemorrhagic fevers, which are quite apparent clinically, but do require confirmation by either any of the rapid tests or molecular or serological tests. And one familiar case we all know is a child, like say this 11-year-old child with high fever, short duration, abdominal pain, erythroderma on the skin moving with some petechiae, with a hepatomegaly, which may or may not be there, but conspicuously disproportionate hemoglobin and hematocrit levels. If associated with thrombocytopenia, we all put a diagnosis of dengue-like illness. But the point to remember is similar dengue-like illness can also be seen with other flaviviruses, Zika or chikungunya, and also other arbovirus, which I recently discussed, a Congo Crimean hemorrhagic fever. What we must remember is while musculoskeletal manifestations are more in Zika and chikungunya, hemoconcentration and thrombocytopenia are exclusive to dengue virus. While clinically we may suspect any of these viral infections, the confirmation always comes from an NS1, which is a highly sensitive and specific test for dengue serology in the second week. But please remember, chikungunya serology occurs later. So maybe after the 2 weeks. So chikungunya serology is not really relevant for diagnosis of an acute chikungunya, and this is where our PCR helps. The Congo Crimean hemorrhagic fever, which came from Africa to India, and interestingly through ticks, which were carried by the migratory birds from Africa to India, and then had a primary human infections followed by a secondary human infections. Fortunately, it got restricted to some places in Gujarat and occasional cases in Rajasthan. But I learned recently that probably some cases have also been reported in South India, probably Tamil Nadu. Essentially, a dengue-like illness, but a major bleeding manifestations, while thrombocytopenia, leukopenia, and a diagnostic PCR clinch the diagnosis, but it gets on added to our tropical fever list when we see a short duration fever with no localization with some kind of a rash. Now, 2 years we have had various manifestations of COVID. So I show you a case who was 14 year, admitted with us in July 2020 with short duration fever, non-specific pain, abdomen and vomiting with some respiratory issues. The patient was admitted with a vasomotor collapse and deteriorated rapidly and had initially diffuse erythroderma rash with progression to ecchymosis. Now, as usual, like we treat them as a septic shock or a dengue, but since that was the first break after the first wave of the COVID, we thought maybe we are dealing with a multi-inflammatory syndrome, which is COVID related. And if you see the investigation panel, all attempts to find out any microbiological clue were negative, except that we had high COVID antibodies. There was a procoagulant state as indicated by the very high D dimers, inflammatory markers all very high with involvement of multi organs and including the cardiac involvement where there was mild LV dysfunction. While the coronaries were mildly dilated, but yet they did not qualify that Z score for a Kawasaki like presentation. However, after our intense effort initially for about 2 weeks, this patient did come out of the illness. And this was our first case in 2020, which we kind of confirmed as a COVID related multi inflammatory syndrome. Since then, many of the dermatological manifestations and MIS has been described in the world literature. So therefore, remember undifferentiated fever with rash, which is evolving and has a coagulopathy with a recent outbreak or spread of COVID, consider MISC. Unfortunately, it is also overdiagnosed, especially post these various waves of COVID, but sometimes I feel it was underdiagnosed also. So now then there are bacterial hemorrhagic fevers, and these two are just spot cases. We see them and we know that short duration fever with these kind of ecchymosis or necrotic patches, we cannot miss a meningococcal infection as well as a necrotizing fasciitis, which can occur with a hematogenous dissemination or a local injury which gets infected. The bug, while here it is Neisseria meningococcus, here it is strep pyogenes, maybe sometimes staph, and if it is a roadside or a soil contaminated injury, even gram negative would come into the picture. Remember, these are two hemorrhagic bacterial fevers which are life threatening and require immediate intervention. So another bacterial hemorrhagic fever to show you a case, 7-year-old girl with 5 days chills and admitted, especially in the post-monsoon period when we had dengue, malaria, and IL. I remember this was before the COVID struck us. So the usual possibilities of a tropical fever with routine investigations are almost normal, and the patient got sicker and sicker with altered sensorium and vesicular lesions appearing on the limbs as well as the face and progressing on to these ecchymotic and kind of a gangrenous patch on the digits. If you see, both the foot as well as the hand digits are affected. While we treated as a gram-negative sepsis, including enteric staph and strep, since it was before the pre-COVID era, so we did not think of any Missy-like syndrome in this. So we treated as a necrotizing fasciitis or a gram-negative sepsis, but the child had multi-organ involvement, multiple brain infarcts, all microbiological clues negative, except that we got a wheel felix, which was positive. Well, not very confirmatory, but yes, suspicion was there, and the child responded beautifully to when the doxycycline was added. And earlier, before that, when was on a broad spectrum gram negative and gram positive cover, there was hardly any improvement in the patient. So, therefore, my friends must remember that, especially in some of the districts, when we are dealing with children with high continuous fever of 4 to 5 days, with an exanthem which looks like a vasculitic exanthem, which may be a pleomorphic, palms and soles are involved, with no respiratory symptoms, no significant lymph nodes, but severe myalgias may be there. These kind of pictures of rash which evolves and some laboratory evidence of a thrombocytopenia, raised inflammatory markers, hyponatremia, raised transaminases, and albuminemia. Please remember rickettsia, commonly seen in Maharashtra, reported also in Himachal, but it is not unusual to have now rickettsial infections being reported from across India. So similarly, another similar looking illness, but again, so there are some pointers, is leptospirosis. Not very common pan India, but yes, there are regions where leptospirosis must be suspected in fevers, sepsis-like presentation, subconjunctival hemorrhages. You may have thrombocytopenia or thrombocytosis with the bleeding manifestation, diagnosed by Fain's criteria and confirmed by MAD test. So leptospirosis again becomes an important DD. So therefore, with all these different presentations of a viral diseases, and some of the bacterial hemorrhagic fevers, I must caution my colleagues that we must keep updating and learning, because if you do not learn, if you stay ignorant, greater is the dogmatism. As a famous quote by William Osler, Suresh also in the earlier session quoted William Osler. So I'm sure William Osler has been throughout his life giving us quotes only. So that was a brief synopsis of hemorrhagic fevers. And I'm sure Dr. Sara would do justice to the laboratory diagnosis and a specific viral hemorrhagic fever. Over to you, Manjula. I am done.
Thank you very much, sir. Can we have Dr. Sara's CV slide, please? Yeah, over to you, sir. Dr. SBS.
I have great pleasure in introducing Dr. Sarah Chandy, who's a molecular virologist in Kanchi Kamakodi Child Trust Hospital, and she's the pillar of our research wing, the Child Trust Medical Research Foundation. She's a doctorate in medical microbiology and virology. She underwent training in the Christian Medical College, Vellore. She has more than 18 years of diagnostic experience, and she has specially worked on orthohantaviruses. Very few virologists in India have worked on this, and she has also carried out PCR studies in dengue. She's also carrying out PCR studies in scrub typhus and enteric fever. Her interests include development of affordable in-house multiplex molecular assays for routine diagnosis. In fact, she has developed a platform for respiratory viral testing in our hospital, which has resulted in several publications. She's also interested in the epizootiology of orthohantaviruses in rodents in India. She's a very, very capable molecular virologist and the right person to talk about specific laboratory diagnosis of hemorrhagic fever. Over to Dr. Sarah Chandy. Thank you.
Thank you, sir, for your kind words. I'll go to my presentation. Share screen. Yeah. Share. So today I'd like to share with this august group of clinicians, and I'm sure there are laboratorians also, my journey with a viral hemorrhagic fever virus, which is now known as orthohantaviruses. Of course, at the time when I was doing my doctoral studies, it was just plain hantaviruses. Is it clear? Am I audible?
Yeah, you're audible, and it's full screen. Thank you. Please go ahead.
Yeah. So I'd like to today present my journey with the diagnosis of orthohantaviruses in India. And as Dr. Chitkara has already introduced viral hemorrhagic fevers in India, they are a group of zoonotic diseases which are characterized by fever and bleeding disorders. They're all enveloped viruses, as we all know, and they have a single-stranded RNA genome. They routinely use rodents, bats, and insects for transmission, and those are their natural hosts. The characteristic feature of all these viral hemorrhagic fevers are that they require a very low infectivity dose to cause disease. And typically, if you look at the circulation of these viruses, they occur in areas which are habitats of their natural hosts. For example, the hard ticks or rodents, specific rodents which carry hantaviruses or arenaviruses. Viral hemorrhagic fever or human outbreaks of viral hemorrhagic fevers are very sporadic. They are irregular, as we have already seen with the earlier talks. And we see a lot of these viruses keep emerging and re-emerging as they get newer geographical areas and susceptible hosts in these newer geographical areas. Now, this slide is just to present the more than one RNA segment. So this is the classification that we use typically. And orthohantaviruses earlier belonged to family Bunyaviridae. Now it has its own family of Hantaviridae. As you can see, the distribution of hemorrhagic fever viruses in around the globe. I'd just like to point out the Indian scenario where we have seen circulation of dengue virus all across the country, Kaisnur forest disease in Maharashtra, Karnataka, orthohantaviruses. We have researched it in Chennai and Vellore. And of course, the others, the other viruses that we have seen, Dr. Chitkara mentioned the CCHF virus, which we believe would have also migrated from Pakistan because Pakistan is known to have outbreaks of CCHF virus. Now, before I go further into the testing systems that we generally use, there have been many questions or many people who have asked me whether we could use, what kind of testing can be used for VHFVs. Now, I would just like to put this slide because some of these viruses, which can be transmitted from person to person, they belong to different risk groups. And everything cannot be tested in routine laboratories. For example, Kaisanur forest disease, we know there can be human-to-human transmission, and they belong to risk group level 3. And WHO recommends that for Kaisanur forest disease, BSL level 2 should be used, but we have a beautiful paper from NIV which recommends using even BSL level 2, which is the level which is commonly seen in different laboratories. Orthohantaviruses do not get transmitted from person to person, so even though it is level 3 pathogen, BSL level 2 is enough. Dengue, as we all know, BSL level 2 is enough. But of course, if you're propagating the virus, you need to use level 3 laboratory. CCHF, routinely, it is a virus which belongs to level 4, and it cannot be handled in routine laboratories. It requires level 3 or level 4 laboratories. Of course, for specimen aliquoting to be sent to the reference laboratory, you could use a BSL level 2 facility. This slide is presented just to inform others that many viruses cannot be handled in routine laboratories.
Audio is gone.
Internet issue, ma'am.
She's disconnected.
Yeah. I'll just call her and inform her.
If it is taking time, we can take up some questions from the audience. Is she able to join? If it is taking time, we can take up some questions.
Yes, sir. She's reconnecting. Meanwhile, if there are any question, I request our audience to post it on the chat box, and I request the RX event to kindly share it with us. Are there any questions in the chat box, please?
Dr. Chitkara, I would like to ask you, is it possible to distinguish vasculitis from viral hemorrhagic fever clinically? In fact, the basic teaching in pediatrics is that if you have a palpable purpura, it is likely to be vasculitis. If you have a non-palpable purpura, it is likely to be thrombocytopenic. And if you have a non-blanching purpura, it's always dangerous. In fact, if you look at the NHS guidelines, you will find the non-blanching purpura as a red flag sign for fever. Your comments, please.
Okay, good question, Bala. So first of all, what is vasculitis? Like you described, it is a palpable lesion because ultimately it is inflammation of various blood vessels, small to medium or others. Now, to differentiate between a viral vasculitis, because most of the hemorrhagic viral fevers would in fact cause all these hemorrhagic rashes because of a vasculitis phenomenon only. So differentiate from a viral hemorrhagic kind of a vasculitis from a collagen vascular or an autoimmune. The first and foremost thing is the duration. Viral fevers are invariably short-lived, while all those chronic systemic inflammatory lesions or autoimmune diseases, you will have long drawn out symptoms. That is why I said these vasculitis, which are of autoimmune or dysregulated immunity, are invariably subacute or chronic type. Viruses, on the other hand, are acute within the first 2 weeks, and by invariably by the end of first week one. Number two, all vasculitic rash, whether caused by viruses or a dysregulated immunity, may not blanch even if they are not purpuric. Yes, they are palpable because it is a local inflammatory reaction which occurs in the entire blood vessel. So one, vasculitis palpable, only the duration differs, plus the underlying spectrum of a chronic inflammatory disease or an autoimmune disease. Like you'll have arthritis, skin rashes of different types, prolonged kind of an indolent course, while viruses strike very fast, 3-4 days high fever, and you go into all these symptoms. You'll have multi-organ failure, but invariably arthritis, eye involvement doesn't occur in most of these viral except these exanthems, except you may have sometimes a conjunctival congestion. If you compare like a Kawasaki, which is again a vasculitis, you'll have bulbar conjunctivitis. But in most of the viral rashes with conjunctivitis, it is very uniform, bulbar as well as a palpable conjunctivitis with or without discharge. So these are subtle differences of duration, the kind of lesions, the pleomorphic evolving. Invariably, joints are not involved, which is more common in the autoimmune or a dysregulated immunity. So these are subtle points which can differentiate between acute viral and the other prolonged disorders.
Thank you, Dr. Skara, for those very lucid answers. I think Dr. Sara has joined back. Can you restart, Dr. Sara? Yes.
Sorry for
It's
the
okay. It's okay.
loss in connection.
Please go ahead.
Yeah, so I just wanted to go through some points of introducing orthohantaviruses. These are rodent-borne, as you know, and each different serotype is hosted by...
Make it full screen, Sarah.
Each serotype is hosted by a specific rodent species. And of course, there are other orthohantaviruses which are hosted by other small mammals like shrews, moles, and even bats. So basically, there are two different kinds of orthohantaviruses. You have the old world orthohantaviruses, which were earlier discovered, like in the during the Korean War in 1950. And you have the new world orthohantaviruses, which were discovered as the, in 1993. And these two different kinds of hantaviruses, or the old world orthohantaviruses, they cause what is called hemorrhagic fever with renal syndrome. And there are 4 or 5 very important viruses which come under the group of HFRS viruses. New world hantaviruses, they generally cause cardiopulmonary syndrome, which is called HCPS. And there are 2 very important viruses, Syn-Nombre and Andes virus, which cause very severe disease. Now, the most important thing to consider here is, since they are transmitted by rodents, you could have domestic exposure. Sorry, sir. So what we need to consider is transmission of infection occurs from rodents to humans either in the domestic settings or it could be in the recreational settings. For example, when there are campers who go out and they get exposed to rodent excreta, please remember aerosols which are generated from contaminated droppings, urine or saliva of rodents can infect humans. There can be occupational exposure also, for example, in farmers, mammalogists, or rodent handlers. This is
Please
just
make
a
it full
slide.
screen again. Full screen, Dr. Sarah.
Actually, I have some problem with my
Okay,
system.
please go ahead. Please go ahead.
Yeah,
Please
so
go ahead.
this slide roughly shows you what different kinds of hantavirus we have. I've just highlighted the ones which cause very severe disease in humans, of which the first and the third are seen in the Asias and Europe, whereas the last two are seen in Americas. This is the transmission of hantaviruses in transmission of hantaviruses. You can see hantaviruses transmit horizontally between animals, and they transmit from animals to humans through viruses which may be present in aerosolized excreta and urine or saliva. Here, this represents the general distribution of orthohantaviruses around the world. You can see the rodent hosts are distributed everywhere. And as I mentioned earlier, the distribution of the rodents or the small mammals, they decide the distribution, or they fix this distribution and circulation of orthohantaviruses. So in Asia, you have a lot of Hantan virus, which is transmitted or carried by Rattus novagicus, or mice, Apodemus, or even what you call the bandicoots, Bandicoota indica. So the distribution of the rodent host actually plays a very important role in the distribution of the different serotypes. Now here I have just very briefly summarized the important clinical features of HFRS, which we saw in the patients when we were doing this study. And very few patients, most of the patients, they presented with acute febrile illness. It could be query dengue, query scrub, or query lepto. Very few of them had kidney failure. And it was seen that most of the cases that we saw, they were mild to moderate in severity, and complete recovery took place. When we look at the laboratory diagnosis of orthohantavirus, there are a wide variety of testing systems that we can use. But since in the first week after onset, since the signs and symptoms are very, very non-specific, usually the patients present at the clinic, usually after the first week. And at that time, serology becomes the most important tool for testing. PCR is very useful if you are able to, the patient appears before the first 7 days after onset. There are other tools which we have used in our study. ELISA, we have used conventional PCR, real-time PCR. Of course, there are a lot of investigators who are using multiplexed real-time system, where you can try to multiplex the different serotypes which may circulate in a particular area. We used Western blot because that was the first time we were doing the study on orthohantaviruses, and we really needed to confirm that our findings were truly correct. We also used serotyping ELISAs. And of course, now microarrays are available, where small oligonucleotides are used as fishing nets to look for different pathogens. NGS can be used for genotyping, and we have been using NGS extensively during the COVID outbreak. Virus culture can be used for orthohantaviruses, but again, it requires level 3 facility, and very few cell lines can be used. For example, Vero E6 cell line, which is not very frequently used in cell culture laboratories. So now I will just go through quickly through my journey and what were our findings. So before I started my study in 1968, already there was a hantavirus isolate which was reported. It was from an insectivore, Sancus murinus, which was captured in Vellore. It got its name from the place where the insectivore was captured. And there is a very beautiful publication by Dr. Carey. And this was supposedly the first hantavirus to be ever cultivated. So when we started our study, we really didn't know what kind of serotype we were looking for, what kind of tools we should use. So since we already had literature that orthohantaviruses could cause even mild acute febrile illness, the first pilot study we did was on patients with query dengue, query lepto, and query scrub, but negative for the respective etiologies. And we found in the pilot study, 12% of our patients were seropositive. We did not restrict ourselves to a single ELISA. It was, we used a heterologous ELISA system, a heterologous system which pooled all the different serotypes that could be present, because we did not know what serotype we were looking for. And the pilot study gave us very good results. And we moved on to another larger study where we started looking at patients with acute undifferentiated febrile illness. So we didn't restrict ourselves to dengue-like or lepto-like or scrub-like. We started moving towards patients with acute febrile illness, acute undifferentiated fevers ranging from 2 days to 14 days. And we got very good results. I was able to do PCR. This was those days of conventional PCR, 2004, 2005. The target was very small. It was only 150 base pairs. And we found that what we got positives by with molecular testing, they showed great homology with Hantan virus. Now, Hantan virus is the one which is commonly seen in Russia, Korea, Thailand, etc. So these were studies on patients with acute undifferentiated febrile illness. Next, we wanted to look at seroepidemiological studies. So we had to, okay, before I go to that, this is a slide which just gives you a rough idea of what could be the clinical and laboratory findings in patients who are seropositive. What was significant is 75% of those who were seropositive or laboratory confirmed orthohantaviruses, they had thrombocytopenia, which you would see in most cases in other parts of the world also. This is a slide which just shows immunofluorescent assay, which we used, and Western blot techniques, which we used for confirming our results with ELISA, since this was the first time we were doing hantavirus research in India. So in seroepidemiological study, we tried looking at healthy blood donors. We looked at go-down workers. We looked at irulas, because we know irulas, they catch rats, they consume rats. We looked at patients with chronic renal disease, because it is believed that patients who have had hantavirus infections, they go on to developing chronic renal disease. So we found that there was a high degree of seropositivity in irulas, which was very significant from the seropositivity, which was significantly associated with irulas when compared to the seropositivity we saw in healthy blood donors. So then once we got seropositivity and we could study seroprevalence of orthohantavirus, we tried to serotype the virus. We wanted to know which virus is circulating in India. And these samples were actually serotyped with the help of our overseas collaborators. In fact, most of the studies we did with material which was generously donated by collaborators from Germany, from Japan, even from the US Army, US Army, we got control slides.
Dr. Sara, you have only 2 more minutes. Thank you. Kindly finish it. Thank you.
Okay, and the last, nothing would be complete in a zoonotic disease without looking at animals. So we did testing on 84 animals, which included rats and bandicoots, and we got similar kinds of results, which we got in human testing. Here too, we used ELISA, Western blot, immunofluorescent assay, RT-PCR, conventional, and real-time. And we found that 19% of the rodents were positive, seropositive. We were able to detect by molecular diagnosis, we were able to detect orthohantavirus from the lung and kidney tissue of one bandicoot rat.
Dr. Sara, you can wind up. I'm getting messages from the organizers. Time is
Yeah,
over.
sure. So this is my last slide, and this is just to convey the message that there are orthohantaviruses which circulate in India, and it is necessary that we consider hantavirus infections in the differential diagnosis of scrub, lepto, malaria, dengue, and other causes of AUFs. So I would like to wind up by just showing you my acknowledgements to all those who have contributed to this preliminary study of orthohantaviruses in India. With this, I wrap up my talk. Thank you so much, sir, for giving me the opportunity.
Thank you. Thank you, Dr. Sara. That was
I'd be
a
happy to take any questions.
Yeah, that was a brilliant presentation from Dr. Chitkara, the stroke clinician, and Dr. Sara, the molecular virologist. I think for want of time, I don't think we can take questions. I would just say that gone are the days where shrewd clinicians used to make a diagnosis of the etiology of viral hemorrhagic fever. These are the days of PCR. COVID-19 has taught us how to use molecular tests for appropriate diagnosis. And any hemorrhagic fever today, if you want a specific diagnosis, you must take help from virologist Dr. Sara for the accurate diagnosis. That's number one. Two, I remember in Chennai, about a decade back, there was overdiagnosis of leptospirosis. Everybody was diagnosed as leptospirosis and everybody was given first-line penicillin. I'm sure majority of the cases would have been hantaviruses. It's time for us to look beyond leptospirosis, look beyond scrub typhus, look beyond dengue, the diagnosis of viral hemorrhagic fever. Over to Dr. Manjula. Thank you very much, Dr. Chitkara and Sara, for those brilliant presentations.
Thank you very much, sir. Once again, thank you very much to Dr. Chitkara, sir, and Dr. Sara, ma'am. It was really wonderful. And to Dr. SBS, sir, who has conceptualized this session and made it so wonderful. Thank you very much, sir. And now we move on to the next session. Our next session is the GC Surana oration. So can I have the slide? So we have two eminent doctors with us to conduct this oration proceedings. And first, I have a privilege of introducing Dr. A. Muruganathan, sir. Sir is FRCP, triple FRCP, FACP, and FPCP, and FICP. Sir is ex-emeritus professor for Tamil Nadu MGR Medical University and immediate past governor of American College of Physicians of India and Dean of Indian College of Physicians. And he's been the president of almost all the medical association, including Hypertension Society of India, Association of Physicians of India, and he has brought out several books. Some of them are Adult Immunization and Progress in Medicine, Medicine Update, and Manual of Hypertension. And he is a recipient of several awards and accolades, including the prestigious B.C. Rai Award from the President of India. And he's been given excellent award in hypertension and prevention control. And he has received the best performing doctors from Tamil Nadu, as well as he has received from Japan chapter of ACP, and he has received the Lifetime Achievement Award from MGR Medical University and Savita Medical University. Dr. Muruganathan, sir, it's our pleasure to have you as the chairperson for conducting this prestigious DC Surana oration.
Thank you very much, Dr. Manjula.
Yeah,
In
one
fact,
minute before
yeah.
I hand it over, I just called an next person, sir. Our another prestigious doctor who will be chairing this session is Dr. M.K. Sudarshan, sir, whom all of you know, and he's been very familiar face during COVID-19. Sir is the chairman of Karnataka State COVID-19 Technical Advisory Board of Government of Karnataka. As he's a member of advisory board of Fever Foundation, ex-director and retired dean and principal and the professor of HOD of community medicine at the prestigious Kempegowda Institute of Medical Sciences, Bangalore. He's a member of WHO expert consultation on rabies, and he's the chairman of ethics committee of Bangalore Medical College Fortis Hospital, and he has been the NABH assessor for clinical trials and ethics committee. He has more than 100 publications both in international and the national journal, authored several books on rabies in English as well as certain books in Kannada. Best Teacher Award from Indian Medical Association and prestigious Dr. B.C. Rai Award for his achievement of excellence of medical education. And he has recently he got the Rajyotsava Award from Karnataka government for exemplary work during COVID, as well as Doctor's Award in recognition of his contribution during COVID from the government of Karnataka. And he has received the Eminent Teachers Award from Rajiv Gandhi Health University. Dr. M.K. Sudarshan, sir, welcome you. I request you to kindly chair the session for prestigious Dr. G.C. Surana oration. Now I hand it over to Dr. Morganathan, sir.
Thank you very much, Dr. Manjula and all the dignitaries, my brothers and sisters. It is indeed a great pleasure to chair this prestigious GC Surana oration. In fact, when all of us, before that, Manjula introduced me saying I'm heading so many things, but she forgot to mention I am also one of the organizing chairperson of the Fever Foundation, because it was our brainchild. We are doing at the 5th year. We are very proud to say, because we are the only people who are spending 2 days only for fever. You know, nobody else does this. So we are very proud, and I want to acknowledge the work done by all of us. And then Jagadish Chinnappa is my good friend. And when we unanimously selected Jagadish Chinnappa, he refused to accept this oration. He said, if I have to do the oration, you should be there with me. I said, okay, but unfortunately, we could not be there. Of course, we are so near, but so far. I can see his smiling face, but I cannot even touch him or hug him or say hello to him. I mean, anyway, mentally, literally, I'm with Jagadish Chinnappa, and as I promised, I'm with you, Jagadish Chinnappa. And he's a very good orator, good communicator. More than that, he's a good organizer. And he's the one person, from the beginning was with us, tolerated all my comments and, all discussions, debates, which we normally do when we chart out the program. Now, I think our Sudarshan had the opportunity to go to the venue and greet him and garland him, all those formalities, rituals, he took it. But I'll have the pleasure of introducing this great man, G.C. Surana. He's a visionary whose life is a source of inspiration to all. In fact, he's a very hardworking person. I know him well. And once, I remember when I was, struck in in a breakdown, I didn't know whom to call. I called him. He sent his car in the middle of the night at 12 o'clock and then, gave me all the hospitality. That's a very nice person, a great personality. Of course, we are doing this oration for the 5th year. And this year, Jagadish Chinnappa is, the person. Last year, I had the opportunity to deliver that oration. Next slide, please. Can I have the next slide, please? Yes. Is Karma Yogi Sri G.C. Surana ji. He was born in 28th April 1941. He hails from the small village of Palrai in Pali district in Rajasthan. Next slide. Has had earlier education at Parswan Jain Vidyalaya at Balrai and held the distinction of being a rank holder throughout his educational career in Rajasthan. Sri G.C. Suranaji moved to Bangalore in the early 70s in search of a job and to earn his livelihood. Being an astute thinker, he identified the prospective business opportunity in the pharmaceutical sector and started his journey as a distributor. Next slide. Independently started Micro Labs Limited in 73 When sheer hard work, business acumen, and respect for people, he has built Micro Labs, which now employs over 12,000 people. His strong willpower, phenomenal memory, clarity of thought, bravery of expression, and accuracy of content, backed by a vast humanitarian approach, provided an inspirational leadership to micro group of companies. And not only he gives inspiration, he also gives inspiration and motivation to his family of this, his academic career and his research activities are being carried out by his family members also. Next slide. And believe that quality of education should be made available to all sections of the society. That's why, these academic activities are going on in various forums. Thanks to Surana. He started the Surana Group of Educational Institution in Bangalore City and firmly believed that service to mankind is service to the God. Donated generously toward welfare, and his contribution is immense in the field of education, health, and religion. Both his sons stood by his side and worked towards developing the industries in international market level by demonstrating the exemplary leadership, virtues, and have henceforth taken forward the legend's legacy. So I think, ladies and gentlemen, my dear brothers and sisters, it is a great honor for me to introduce this oration and the orator. I think my colleague Sudarshan will introduce the Jagadish Chinnappa, and all of you will enjoy this wonderful oration. Before that, there'll be a short video of felicitation to Jagadish Chinnappa, and then after that, our beloved friend Sudarshan will introduce Jagadish Chinnappa and he will deliver his oration. Over to you, Manjula, for the formalities and the video presentation.
Yeah.
Thank you.
Over
Thank
to-
you.
yes.
Yeah. Thank you, Dr. Muruganathan, and thank you, Dr. Manjula. I think we will have the first slide of Dr. Jagadish Chinnappa. I will introduce him to the audience, and then the formal felicitation video can be played. So, and I also thank Dr. Manjula for introducing me to the audience. So I am extremely happy, and it gives me immense pleasure in the true sense to introduce Dr. Jagadish Chinnappa, who is the one of the most popular pediatricians in the state, and particularly in Bangalore city. And he is the consultant cluster head pediatrics at Manipal Hospital Groups in Bangalore, and he is the past president and of respiratory chapter of Indian Academy of Pediatrics 2019 to 2021. He is the CEO of MedTrain LLP Bangalore, and he is the consultant at Child Central Clinic Bangalore, which is a very popular pediatric clinic. And he is involved in teaching undergraduate medical students, postgraduate students, and nurses, and primarily the DNB students. And he was the president of IAP BPS in 2007, and he has been an examiner for MD Pediatrics from 2007 onwards. He was the organizing chairperson of FeFCon 2017. He is certified in pediatric bioethics from the Mercy Children's Hospital, Kansas in 2015, and is also certified by the Karnataka Medical Council and the Mumbai Medical Council. He is a member of the Hospital Ethics Committee, Manipal Hospital, during 2012 to 13 and 2019 onwards, and he is a member of the Immunization Subcommittee of IAP 2007, and he has been a very active member and a participant of the COVID-19 Pediatric Task Force in Karnataka. So he has been unanimously chosen to deliver the oration lecture, and usually as per convention and propriety, after the lecture there will not be any questions. Maybe in the chat box, if there are any interesting thing, it is between the Dr. Manjula, Dr. Muruganathan, and it can be passed on, and he can take up those if the time permits. So with this, I stop here. And
but Sudarshan,
yeah.
I have a small question. Why don't you show your face? Because without seeing your face, we are, please, open your video.
No, because there was some background problem. So
no problem.
Yeah. So Yeah, thank you, thank
Yeah,
you.
at
Yeah,
least
yeah,
we
I
are very
forgot.
happy. Yes,
Yeah,
yes.
yeah, yeah. I will keep it like that. Thank you very much.
Yeah.
So it is now over to Dr. Manjula and Dr. Jagdish Chinappa. I think we'll have the opportunity to now felicitate Dr. Jagdish Chinappa, which is a very pleasant
Yes.
experience for me. And over to Dr. Manjula, please.
Yes, sir. Thank you so much, both of you. Can we have the felicitation video, please?
Yeah, I think with this felicitation, I now invite Dr. Jagdish Chinappa to deliver the oration lecture. Over to Dr. Jagdish Chinappa.
Respected Dr. Muruganathan, Dr. Sudarshan, and all my members of the Fever Advisory Board, thank you very much for this honor today evening. I have already recorded this oration, so I would request the organizers to play the recording. I thank all the members of the micro labs, Mr. Jairaj, Dr. Manjula, Dr. Kishore, Dr. Praveen, and all others also for giving me this honor of speaking today. So, can we have the recording, Dr. Manjula?
RX event, can you start? Yeah.
It gives me great honor and privilege to present the Shri G.C. Surana oration of 2022. The subject will be management of fever, past, present, and future. At the outset, I must place on record my immense respect for Shri G.C. Surana, who was a visionary and a source of inspiration to all of us. I knew him personally, and he has been one of the most philanthropic and friendly persons that I have ever met in my life. He has been a role model for all, not only at micro, but in the medical fraternity, for his simplicity and his vision of how things should change over the coming decades. I also place on record my thanks to the Surana family, Mr. Dilip Surana, Mr. Anand Surana, and their respective families, whom I have known for many, many years and who have been very close friends and mentors for many of the things that we have done in the Indian Academy of Pediatrics and outside. I also place on record my immense gratitude to Microlabs for the support for so many years, led by Mr. Jairaj, Dr. Manjula, Mr. Praveen Singh, Mr. Girish, Dr. Krishna, Mrs. Abira, and all others. The Fever Foundation, which has been launched 5 years back, has been outstanding in its efforts to spread the message of how fever is a major problem in our population and the different causes of it and how it should be handled. To lead this has been a group of very exemplary and illuminating people. Professor Maya has been at the helm of things. Dr. Muruganathan has been a source of inspiration for all of us. Dr. Sudarshan, Dr. Ravindra, all my physician colleagues and pediatric colleagues. Thank you very much for this opportunity for me to present this oration today. Now let's start. Fever. And we're living in the distant past or even in the recent past. How we are living today, or how your child had fever, and how you're going to take in the present circumstances, and what do we think is going to happen to fever in 2090 AD. This will be the breakup of my talk to understand how this whole scenario of fever and its management has changed over the last centuries, and how we are going to look at it in a very different way in the future. Let's start with the past. Now, starting with the past, I will break it up into two: the philosophy of fever and the management of fever. Now, let's look at the philosophy of fever. A very interesting article on the cultural history of fever was that in much of human history, as it is even today, many people believe that fever or a rise in temperature was a supernatural being. Fevers were sinister, uncommon, unnatural, but real. They existed. In Roman times, Febris, the Roman goddess of fever, was also a goddess which protected people from fever and malaria. The Romans had at least 3 temples dedicated to worshipping this god, and they would leave amulets in these structures to relieve them of fever. So Febris was very real even in Roman times. In our traditional times in India, Jwara is what we call fever, also called Jwarasura. Sura is a demon, is the personification of fever in Hindu tradition. He is the consort and sometimes the attendant of the pox goddess Shitala, which is another very important concept in Hindu philosophy. Fever in Ayurveda, this is a very beautiful book written by one of the pediatricians from Mumbai and my teacher, Dr. Athavle, and he has written a very extensive treatise on how fever was looked at in Ayurveda and taken care of. In the Middle Ages, there were fever treatments included incantations, elixirs, charms, and exorcisms to get rid of the supernatural aspects of fever. Then we moved on into the 1600s, where there were 4 basic concepts that were pervasive in the looking at fever. One was that it was external. It was not something that happened within the body. It was something that happened, something outside of the body. It was mysterious because people didn't understand what it was. They thought that fever itself was a disease. It was paradoxical because when the patient had fever, he also had chills and rigors, and he would get well with intervention. Some of them would die. So it was a paradoxical kind of situation, and it was also protective to some extent. Thomas Sydenham in 1660s wrote that fever is a mighty engine which nature brings into the world to the conquest of our enemies. That means fever can also be protective. So some of these were the concepts that were there as far as fever is concerned. Again, in the 16th century, people thought that heat was outside the body, and they regarded this as something magical and extraordinary. And this is a distinct kind of heat contrasting with other kinds of heat. Now, what happens when this kind of concepts are there in people? They lead to different perceptions of fever. People don't like fever at all extent, at whatever ages. They don't like fever for various reasons. The larger attitude towards fever is that it is socially and culturally mediated through generations of misinformation and suffering. So there has been a lot of things that have been attributed to the cause of fever. Now, there are cultural practices which keep varying from cultures to culture, but what was unifying was fever phobia. And this phobia, or the fear of fever, has been there from time immemorial. And what is seen today in parents is basically an extension of this phobia, which is there in all socioeconomic groups. And even today, if you look at parents, they are worried about fever because of the potential harm that it may cause to their children and to themselves. Now, what happens when this fear happens? It is also understandable, no doubt. Even today, temperature in a newborn is a medical emergency. And these children are subjected to taps and urine cultures and whatnot. They're given IV antibiotics even before any other problems take place. And hospitalization is a common reason, whether it is serious or not. Another thing is febrile seizures, which we will discuss a little later, which is something which is in the realm of the unknown. And children, 1 in 5 child can get the febrile seizure, and therefore you can land up with various. The most of them will outgrow these seizures, but it can be frightening for the caregivers. So it continues to perplex, no doubt. It's not always a sign of passing virus or benign disease. The perplexing conditions of doctors are persisting fevers for no cause, or PUOs as we call them. Many physicians still do not understand how to manage these fevers, even though they are the most common health problems. And a significant number of doctors had a serious lack of knowledge of the nature, dangers, and management of fever in children. So these are some of the things that are still continuing to perplex us and which are legacies of the past. And it was considered a disease. Previously, it was thought that it came from the heart, and the heart was the source of the fever. But now we know that the cause of fever is high up in the brain, and it's in the in the hypothalamus. And Hippocrates was himself said that basically nobody knew about microbes, so fever itself was considered a very bad disease. And they were all worried about the outcomes, because many times people would die of fevers, and then you would start worrying about the fever as the cause of death and not the disease as the cause of death. And that was a scary stuff. Sometimes you can get bacterial pneumonia, which you can resolve, or you can die. So it's again an unpredictable disease. So moving from the 16th century and its legacies to now the 18th and 19th century, what happens there? Evidence of these movements were everywhere. In the 18th and 19th centuries, there are many people who are trying to give tonics to cure fever. There were also a large number of obituary, because newspapers came in, and there were people used to write about how people died from fever. And then people started dying of rashes, and then we know that it was measles. Then they died of something else, and they used to put it as smallpox. So therefore, there was a various number of disorders that came into place in the 18th and 19th century. Now, again, the focus in the 18th and 19th century was not on the cause of fever, but the focus on fever. And they tried to treat these fevers themselves with various conditions. One of the other basic problems was, or one of the basic philosophies was, what was called as unbalanced humors. There was a philosophy that each of us had different humors in our body, and because of these bad humors, you had fever. And if you looked at it, people were made to vomit, they were made to sweat or to have diarrhea. And the worst of them, some of them were bled. There was bloodletting was very common to treat fever. The idea of fever will go away, all these things was there. And people thought that all the fever will go away from the pores and orifices if they looked at these issues. So people believed that the pounding of the heart generated heat, as we had mentioned before, and that therefore they misinterpreted the rise in heart rate with fever as the cause of fever. So these were some of the issues. And the Italian physician had a beautiful tree which he had drawn, which showed that the various febrile illnesses, and this was in 1712 or between the 18th century or so. Now, coming to terminology, even into the 20th century, people didn't understand that fever is only a symptom, but still they started adding adjectives to fever like yellow fever, typhoid fever, scarlet fever. So fever remained the focal point. It could be the cause of death, right in the name of the most terrible diseases you could get. So the philosophy of fever is still a work in progress. Even today, doctors debate the proper treatment of newborns with fevers. We still do not know. There are so many questions in medicine, and we say it depends. As early as 1970, they were wondering whether if you get fever, will you actually kill off an infection? Is it likely to be protective? Well, there is some proof to that. We really don't know. People used to induce fever to get rid of diseases like syphilis, and that was another issue. Now, the community responses to fever is that the person may not, the fear which was there is always there. But as you can see in the COVID pandemic, like example in Fiji, what happened? There was an epidemic fever which they never had seen for thousands of years, and many people died. Their body was turning hot and cold, said they didn't know why. And if you look at COVID now, people ran away, ran to villages, and they locked themselves out and burned them. And if some of them were sick, they used to lock them up and burn them down so that it doesn't spread. So the responses in the community was also pretty catastrophic in the past. Now let's look a little bit. We have looked at how fever has evolved in its philosophy over centuries. Now let's look at the treatment of fever. The treatment of fever, very, very interesting. Many years back, many centuries back, the willow bark was commonly used by many of the civilizations to treat fever. The Sumerians, who are at least dated to about 3,000-4,000 years before Christ, were the people who started using this willow bark for treating fever. Then we had Hippocrates, who advocated the use of the willow bark for treating fever. Then we had ancient Egypt, which had also advocated the use of the willow bark for treating fever. So, in addition to this willow bark, there are many other medicines which have been mentioned in various systems of medicine. If you look at the number of herbs which have been used in various cultures for treating fever, it's quite interesting. And they've also looked at various ways of doing it. Like, for example, in the Persian system of medicine, they have looked at how to look at evacuation, retention, how to take care of manual interventions, how to take care of like phlebotomy, which we had talked about, how to look at sleep and various other issues for managing fever. In Shushruta, for example, there are various methods which were looked at for treating fever. And if you look at the treatment, they have looked at astrology, they have looked at maturation of past sins, what is called as karma vipaka, and they have looked at various methods of treatment like chanting mantras, etc. Now, synonyms, there are a number of different types of fevers. Ayurveda had many synonyms for this. There are medicine, if you looked at, this is a very recent paper about 12 years back, which showed that medicinal plants for fever have also been there in our traditions. Now, there are a lot of home remedies which have been looked at, like, for example, basil, tulsi, soft cloth, onion, raisins, ginger and turmeric, neem tree flower, green chirayata, mustard oil, apple cider vinegar, garlic, giloy, satwa, clove. So many things have been recommended for treatment of fever in children. There are also things about what not to do, like, for example, very simple things like medical advice: do not give cold water during fever, never rub ice or alcohol, which we all know. And we also looked at some of the other things, like, for example, what kind of diet to give. Now let's get back to the willow bark. What happened to willow bark after the initial enthusiasm which many of the ancients used for treating willow bark? It was totally forgotten by most civilizations. Then Reverend Edward Stone was sitting under a tree, and he used this willow bark as an antipyretic, and he discovered that it worked, and he called it that it was something which was similar to the Peru tree which the ancient civilizations had used. He published his work, and as you can see in the Proceedings of the Royal Society in 1763. And there was very little excitement even after he had published this, that it is a Peruvian bark and it could be useful in fever. Then, after many years, in 1828, you can see almost about 75-80 years had gone by. And this was Johann Andreas Buchner, who was working in Germany. And he isolated salicin from willow bark. This was one of the most important things that was discovered at that time. In 1850, this is another Italian scientist who converted salicin into sugar, and a second component becomes salicylic acid. And he discovered what is called as the acetyl salicylic acid, or aspirin. But the popularization of this was to this very interesting physician from the UK, who was from the Dundee Royal Infirmary. And he used to treat a number of patients with typhus, typhoid and smallpox. And he is the person who popularized the use of salicin. He was one of the first to use thermometry. Then Carl Duisberg is a very interesting man who got the attention of this product, and then he moved to Bayer into pharmaceuticals. And this is where he started working on this particular molecule. And he also discovered, or rather was helpful, he has supported the discovery of the first effective antibiotic called Protencil. Bayer then became one of the major manufacturers of aspirin across the world. It was called acetyl salicylic acid. They used to send free samples to doctors, pharmacists and hospitals way back in the 1900s. And there was a lot of hype about this drug because it was very useful in the management of fever. Then there was the World War One, and as World War One, the world was gripped by the Spanish flu. In addition, World War One ended, the Spanish flu came into a big problem, and here Bayer aspirin sales skyrocketed, but many people believed that it was this aspirin which was causing the flu. And therefore, what happened was the aspirin was started to be manufactured in America itself. So if you look at this very interesting story of aspirin, it has gone through a big cycle from prehistoric times to now. Now we come to the rival. The rival enters now. And who is this rival? Hermann Otto Morse again synthesized paracetamol at Johns Hopkins. As you can see, Sir William Osler sitting there, and he did this in 1877. But it was completely forgotten. Then in 1886, there was a major medical error. This was a patient who was suffering from worms and fever, and the treatment prescribed was naphthalene, and incidentally or accidentally acetonolide was given instead of naphthalene. What happened next was the worms remained because acetonolide doesn't work in worms, but the fever disappeared. So the very interesting astute clinicians discovering the error, Paul Hepp and Arnold Kahn approached the chemists at Calais and Company, where Hepp's brother, one of the doctor's brother, was working, and suggested that acetonolide might be a useful pharmaceutical. Calais and Company conducted a number of investigations into acetonolide, and finding that it did have fever-reducing properties, put it on the market as a medication. Anxious to hide its real identity, they sold it as a compound called antifebrin. Though acetonolide was discovered in 1852 by the French chemist Gilles Gerhardt, acetonolide was still considered an obscure drug at this time. Then again, due to this man, Carl Duisberg, whom you have seen in the aspirin story, he again started looking into a further research into this product. And he successfully refined this drug and called it acetophenetidine, and that was the first marketing of phenacetin. Phenacetin again was a big success. Just imagine a pharmaceutical company, Bayer, had two major products to reduce fever, aspirin and phenacetin. Then Karl Morner of Germany then looked at this compound acetonolide, and then he saw the correlation between acetaminophen, or what we call as paracetamol, and discovered that acetonolide, when it is metabolized in the body, becomes acetaminophen. Then Dr. Joseph Freire von Behring was the first German physician to synthesize acetaminophen from de novo. And he, through this research, showed that the drug was effective against pain and fever, but he recommended that extensive investigation should be done into all analgesics and antipyretics because they still had significant side effects, methemoglobinemia and also aplastic anemia. And therefore, he was very concerned about this. This drug again was not prescribed or studied further, probably because of the success of aspirin. Aspirin was a very popular drug, marketed aggressively, so it was forgotten completely. So then again in 1949, there was a research on this chemically related drug, and there was a revived interest in the compound. So modern research techniques and clinical use was looked at, and the effect and safety of acetaminophen as a fever and pain reliever were looked at. Then at this point, biochemists David Lester and Leon Grenberg showed that the body not only metabolizes phenacetin into acetaminophen, but also that acetaminophen is as effective as phenacetin. Acetaminophen even had the advantage of not causing methemoglobinemia and is not carcinogenic. And that is the use of acetaminophen, which was definitely a better compound than phenacetin. Then Julius Axelrod and Bernard Brody demonstrated that this drug were both, that is acetonolide and phenacetin, which were previously marketed, was metabolized to paracetamol, which is a better tolerated analgesic. Because of these discoveries, paracetamol was launched as an analgesic in the United States as Tylenol in 1955 and Britain as Panadol in 1956. Now, another interesting story about the use of antipyretics is the hangover that led to discovery of ibuprofen. Dr. Stuart Adams, who was a researcher in Boots pharmaceutical company in the UK, found that he had discovered a new painkiller which cured his hangover just before an important speech. So he says, I was the first to speak and I had a bit of headache after a night out with friends. So I took a 600 mg dose just to be sure and found it very effective. And this was how a drug called ibuprofen was discovered in 1960s and subsequently launched in the 80s as anti-inflammatory and antipyretic drug. Now, what are other drugs which are also discovered? Claude Winder from Park Davis invented mefenamic acid in 1961, but it had significant side effects and therefore primarily used only as an analgesic, not as an antipyretic. Then nimesulide was launched in Italy for the first time, but then again in 1985, but this drug had significant side effects and therefore this was suspended, that the Indian government has suspended the use of this in children under 12 years of age after 10th March 2011. So we have looked at the past. The past has been very interesting. I'm sure you'll all agree with me. Now, what happens to the present? The present, let's look at the pathogenesis. We now know that infection is the most common cause of fever. Fever is also common finding in various other things like autoimmune diseases, malignancy, hypersensitivity reactions, allergic reactions, etc. This is mediated by endogenous pyrogens in response to exogenous pyrogens, which ultimately upgrade the set point. The body reacts by increasing the heat production and decreasing the heat loss. Fever, in contrast to hyperthermia, will not climb up relentlessly because it is controlled by the hypothalamic center. Cytokines play a pivotal role. The production of fever is simultaneously with lymphocyte activation and constitutes the clearest and strongest evidence in terms of the protection role of fever. In fact, the WHO says that do not treat a fever less than 101 with any antipyretic. The protective process of the immune response are optimal at high temperature. Not all effects resulting from fever generate benefit to the host. Some are harmful or even lethal. Like, for example, if there is a cytokine storm or an imbalance between cytokine and their inhibitors. So these are some of the main things that we now know as the pathogenesis of fever. So there is a very, very interesting article which shows that basically there are 2 or 3 methods by which this can happen. You can have the humoral pathway, the neural pathway, and an unrecognized pathway, all of them acting and producing effects on the hypothalamic center in the brain, which can then raise the set point and cause fever. So the humoral transmission of pathway again ultimately leads to a production of PGE2 due to various endothelial damage, and you can get toll-like receptors for which can induce COX-2 to be converted to PGE2, and this produces the fever. You also have the neural transmission due to various reasons. I'm not going into too much of the details of this, but just to remember for most practitioners that there is a humoral mechanism, a neural mechanism, and an integrated mechanism where you can have various groups of disorder conditions which can up the PGE2, which then produces the fever. Now, as far as management is concerned, what is known as paracetamol is the drug of choice for reducing fever. Additionally, when taken for common cold, paracetamol may relieve stuffed or runny nose. This is a matter which we can understand very importantly in our practice, because many children come with runny nose and fever. It does not help sore throat, malaise, sneezing, and cough. Paracetamol is very useful for pain. It also helps in ductal closure and PDA in the newborn. The association between paracetamol use and asthma has been one of controversy, but recent research suggests that there is no such correlation. Paracetamol is available in oral suppository in IV forms. Aspirin should not be given to children, basically because of the risk of Reye syndrome. It's a very, very dangerous condition, and it can happen when children take this aspirin along in a viral infection. Ibuprofen is generally recommended for children over 6 months of age. Dose is 10 milligram per kilogram. It works faster, and duration of action is 6 to 8 hours. But it has significant side effects like gastritis and gastrointestinal bleeding. The other question which we have is, should we use only a single agent, a sequential agent, or a combination? Basically, combinations are definitely no-no. As far as sequential, there have been many studies which we have looked at, and sequential dosing. What is basically required is use a single agent. Now, again, prophylactic paracetamol for febrile seizures is not recommended. Basically, it is a prophylactic use. It's used only when there is fever and when there is significant risk for combination. So again, coming to combination, the American Academy of Pediatrics have suggested that there is no benefit of either combining paracetamol or ibuprofen or alternating between the two when treating fever. Therefore, we should stick to only one of them. Now, how long does it take? Usually, paracetamol takes about half an hour. Paracetamol supposedly takes even longer, maybe up to 1.5 hours, and oral ibuprofen acts faster in about 15 minutes time. Now, let's look at what are the evidences for beneficial role of fever. Now, the human febrile response, if you look at phylogenetically, it has been basically a human immune response which has been necessary to allow organisms to survive to reproductive age. So therefore, this febrile response has happened many years back, almost about 500 to 400 million years back. And today, it is the sharks that are on the thermal regulation of immunity. We know that the hallmark fever response during infection and disease has been maintained throughout so many hundreds and millions of years. And they boost the probability of an effective immune response. And that is what is most important. The cytokine IL-6 contributes to two phases of the febrile response. It not only elevates the core body temperature, but it also acts on the lymphocytic trafficking into lymphoid organs. There is emerging evidence that adrenergic signaling pathway, which we looked at the neural pathway, can also influence immune function. Therefore, fever serves as a systemic alert that broadly promotes immune surveillance in the setting of infection and disease. So we now know that there is some degree of immune regulation when fever takes place, and all fever is not bad. Now, coming to therapeutic role of fever. Well, we know in the past people have tried that, inducing fever for treatment of things like neurosyphilis. Now, recently there has also been some studies which have looked at producing or giving fever when patients have cancer, and they've shown that some of them may respond when they get high fever to the destruction of these cancer cells. This is still in the experimental role. It is not in the clinical arena as yet, but a good thing to think about. Fever paranoia in current times is as bad as it was many years back. And the reason is because of the legacy of so many years of fever that we have had. Now let's very briefly look at what the future holds. The future is, I'm going to discuss in four main groups. One is omics, one is computing, wearable devices, and drug discovery. Now coming to omics, what is omics? Omics means we are looking at different pathways in the synthesis of protein and amino acids, which are the ultimate thing. So now if you look at genomics is where you have different genes and which will determine your response to fever, which will determine your getting fever, how high it's going to go, etc. We look at some examples later on. Then you have transcriptomics, you have proteomics, you have metabolomics, you have glycomics, you have lipidomics. You have various omics which is coming in. And interestingly, I must tell you that recently there was a very interesting study which was done to look at whether we could predict the outcome in severe COVID. And they looked at various factors, the genetics, the metabolomics, etc., and the proteomics. And they showed that it was basically the metabolomics which could differentiate between those who survived and those who died when they got severe COVID. So it's a very interesting field, and it's going to come in more and more into the future. This is an article which I think everybody should read, and this is racial differences in detection of fever using temporal versus oral temperature measurement in hospitalized patient. And what it showed was, this is a multicentric study, and they looked at how the measurement of temperature varies between black patients and Caucasian patients and white patients with infection. And this is a very significant thing. That means for the same degree of infection, a person who's black will not be detected with fever as often as a white patient, and therefore could go into more serious complications. Another thing, very interesting thing is, this is familial Mediterranean fever. This is basically machine learning, looking at variants, and they showed that there are different variants identified with different continents. And therefore, this way of looking at various syndromes and various fevers is interesting. TB pathogenesis. This again this is a very interesting paper which shows that there are different pathogenetic pathways for tuberculosis, and fever is a manifestation depending on what kind of immunological reaction you have at every step. I'm not going into details of this, but this again we had discussed in our last FeFCon of fever and tuberculosis. Another very interesting thing which has come out of Durban, South Africa, is on the pathogenesis of fever-induced febrile seizures. Why do some children, we looked at almost 1 in 25 who get these seizures. And if you look at this, it's basically because of a transmission across the blood-brain barrier of a particular IL-beta interleukin. And when this goes there, it acts on the glial cells. It disrupts the GABA neurogenic transmission and can produce febrile seizures. Again, this is the pathogenesis, as you can look here, that there is a microglia which is activated upon by various interleukins, and this can produce a kind of a seizure pattern in these children. So therefore, some children, when they get seizures, have probably an overproduction of a particular interleukin and a breakdown in the blood-brain barrier which can produce seizures. Even when you looked at this recurrent febrile seizure and serum cytokines, interesting study which showed that the serum cytokines in recurrent febrile seizures was different from those who had no seizures or those who had single seizures. Again, COVID, very interesting on the pathogenesis and why you have prolonged fever, why you have recurrent fever, basically because of various inflammatory markers that are released. So again, neural mechanism of inflammation, reduced fever, various issues are looked at, and we know that the prostaglandin E2 is the one which is crossing into the blood-brain barrier, affecting the glial cells and producing the seizure. Another important thing which has just started research is like we have a microbiome in our body. Children also have a normal human virome, and how this virome interacts with the other virome which enters into the body and produces fever. Then let's look at advances in computing. We have huge number of things that we come in here. Now, like for example, this is a study which looked at 4.4 million body temperature measurements in 1.6 million antibiotic treatment records. This is a way where you can look at big data to identify and what is your effect of treatment. Another study, again based on computing, looks at how pediatricians across a community manage fever and what are their indications for starting fever and what are the outcomes. Then you have another one which looks at this is from Netherlands, which looks at serious bacterial infections in a little more sophisticated manner. This again is a recent paper which looks at procalcitonin. Then let's look at wearable devices. This is again very, very important because again, remember that we are measuring temperature only intermittently. But we need, if we look at it on a regular basis, we may get more information. This is a very interesting paper looking at vital signs in pediatric oncology where you continuously record on a wearable device. And therefore, what you can do is you can pick up an infection much, much faster than you would have by just patient recording the temperature. So this is a wearable technology you can look at. Now, again, we know that non-contact infrared thermometers are what we have been using for a long time. But again, this is not a wearable device, but this is a non-invasive way of measuring a temperature. But please remember that there are a large number of these which are available now, and they may not be actually reflective of what the real temperatures are. Now we'll come to another thing. This is a traditional method of drug discovery where we take about 5,000 to 10,000 compounds, look at a preclinical of about 250 compounds, clinical trials 5 compounds, and get one new drug. And this used to take many, many years to run through all these kind of things. Now with AI and machine learning, we can bring down the cost by almost $2 billion, which is phenomenal. So you can bring down the drug as much as 70% for any drug, and you can bring the drug to market in a very short time. A large number of drugs which are there, which are undergoing trials right now to see whether any of these will work. Remember, we have artemisinin, artesunate, which came out for malaria from one of these kind of trials. So we probably will be looking at more interesting drugs in the next few years. So the management of fever has undergone a huge change over the centuries. My endeavor was to just bring to the notice of how this has taken place in the last centuries and what we are looking for in the next few years. So coming back to our question, if you are a person many, many years back, probably you would have been on an amulet and worrying about how to take care of yourself. If you had been in just a few years back, you could have got a very toxic drug. A drug could have harmed you quite significantly. Whereas now you have safe drugs, and in the future it may be personalized medicine, which where you could identify exactly what kind of infection is causing your fever, what inflammatory markers are elevated, and how you can take a very targeted treatment to manage your infection, inflammation, and fever. Thank you very much for a
Thank you so much for the excellent oration, Dr. Jagdish Chinnappa. I'm also happy to see what is in 2090, your imagination. I wish you should live that long, and I should also come there and chair the same session in 2090, the same topic. I wish and pray. And no, you are right. Precision medicine has come, personalized medicine. But whatever has come, whether it is present, past, future, nothing like personal touch and empathy. Whatever artificial intelligence, anything, can come. But artificial intelligence cannot replace a personal physician, touching physician. And physician with artificial intelligence will be better. That's what, now we have concluded. Anyway, Jagdish Chinnappa, once again, thanks. And because it's an oration, we are running short of time. Already our chief guest, Randeep Gularia, has come. I now request, all of you, wherever you are there, don't stand, give an ovation for that oration. Don't stand now, give the nice round of applause for Jagdish Chinnappa. Now over to Manjula for the next inauguration.
Yeah. Thank you very much, sir. So we are just moving to the inaugural session now. We have with us the eminent doctor and the ex-director of AIMS, New Delhi, former professor and head of the Department of Pulmonary Medicine, and who is known to all of us during COVID time, is known for his wonderful work. I request Dr. Muruganathan, sir, to chair this session and conduct the inaugural session. Over to you, sir, Muruganathan.
Thank you, Dr. Manjula. In fact, we are looking for a real apt chief guest for this fifth Fever Foundation conference, where there are about 36 to 40,000 people are there. And who will be a better person than Padma Shri Professor Randeep Gularia? Of course, he is the former professor and former director of AIMS. He is a member of National Task Force of the Government of India, member of Empowered Group 2 created by Prime Minister's Office, recipient of Padma Shri, B.C. Roy, and Doctor of Science, Doctor of Decade Award, awarded in many forums at various professional organizations, chair and member of various prestigious national, international committees, and member of different national bodies to formulate guidelines, and member of Oversight Committee of MCI, 460 publications and 350 invited lectures at national and international forums. So I think Randeep Gularia will be the best person to give the keynote address, also inaugurate this fifth annual conference of FeFCon. And Randeep is always kind to us, is very close to us. In fact, he had been to our program, I think 2 years back. We really wanted him to come in person. He's always a flying person. Just now he came from Bhopal. He was there in Nagpur yesterday, today in Bhopal. If there is a live program, he would have flown from Bhopal to Bangalore. But he has gone back to Delhi and he is very comfortable. Now he'll present. First, I think, Manjula, shall we have the inauguration and then keynote address? Or keynote address and inauguration?
Sir, as you say, sir.
I think we'll have the, if you have everything ready, just have the inauguration and then we'll ask him to give the keynote address. I request Jairaj or somebody from Micro can also welcome our Randeep Gularia sir, and then we'll have the inauguration. Manjula, you can do or Jairaj can do. We'll welcome Randeep, and if there is any visual prayer song, we can do that, and then Randeep will give the inaugural keynote address.
We are really honored to welcome Dr. Gularia sir. Happy to have you here, sir. Warm welcome.
Okay. Can the RX events play the inaugural song, the prayer song, Saraswati Vandana or something like that, so that we'll have lighting the lamp also, if possible, virtually. Otherwise, we can straight away go for the his keynote address. RX events, are you ready with Saraswati Vandana and the lighting of the lamp? Hardik?
Yeah.
It's good to see Manjula is, lighting the lamp. Apt person who has done a lot of work on this. She deserves to be the person who can light the lamp. Not only this program, the whole Fever Foundation. So we are very happy. And then Maya is doing the honors. Professor Maya and Sudarshan. Yes. If we have the song also, we can play the song. If there is Saraswati Vandana song, otherwise we'll go directly to Pandit Gloria sir, and he is going to give a keynote address after inauguration, and he has chosen a topic: COVID-19 booster dose beyond booster, COVID beyond booster, because many of us are worried. Now there is so many variants have come in Singapore. I had an alarm that this COVID is so very dangerous, spreading fast, very toxic, and all that. So I think everybody is scared. Somebody asked me, should we start from the beginning, like what we had 2 years back? Again, we'll have to follow the same thing. So we listen to Randip, and before that, we request our honorable director Randip Guleria to bless us and then give the keynote address. Over to you, Randip Guleria sir.
Thank you very much, and good evening to everybody. At the onset, let me really congratulate the organizers for this 5th annual conference of Fever Foundation of India. This has grown in leaps and bounds with the number of people attending this conference, and I think it's very, very important because fever is a key symptom, and as we just heard, not only for infectious diseases, but even for non-infectious diseases, the approach to fever sometimes becomes a big challenge. And we've had an evolution in terms of how we have managed fever from a time when people would give empirical treatment to now a lot of investigation being done. And as Dr. Muruganathan mentioned, the importance of talking to the patient, communicating with the patient, because sometimes you may pick up things which may help you in diagnosing fever, which you may otherwise have missed. I remember as a resident, a patient had even a kidney biopsy for diagnosis of fever, and then subsequently on the history, it turned out that the patient was taking some alternate medicine drugs, which was the cause of fever, and once that was stopped, the fever went away. So sometimes just communicating and talking to the patient and being able to really find out what he or she is taking, which may be causing drug-induced or fever because of medication, is also important. I'd like to take this opportunity to really congratulate the patron, Dr. Maya, the organizing chairpersons, Dr. Ravindra, Dr. Muruganathan, Dr. Chenappa, and Dr. Jayaraj, the organizing secretary, for really working so hard. Dr. Manjula also for all the work that they've done and really made this conference a huge success. So my best wishes, and I'm sure that the next 2 days are going to be a huge educational feast. You have a lot of activities lined up, from quiz to talks on artificial intelligence to fever pe charcha, and of course a lot of interactive sessions. So my very best to the organizers, and I'm sure this is going to be a great success.
Thank you, sir. Thank you very much.
Thank you very much, sir, for
Thank you very much, sir.
Thank you very much, sir.
For the nice inaugural address, and your presence itself makes this conference a special one, sir.
Absolutely,
So
sir.
now over to you, sir, for your talk on COVID vaccination beyond the booster. Because every one of you know the role played by Dr. Randip Guleria in the COVID control and COVID vaccination. So he's the right person to give this talk on COVID vaccination beyond the booster. Over to you, sir.
Thank you very much. I hope my slides are visible.
Yes, sir. Can you make it a slideshow, sir?
It's not on slideshow?
It is, sir. It is on slide, sir. It is, sir. It is.
It's on slideshow. So can you see the next slide now?
Yes, sir. Yes, sir.
So what I'm going to be discussing in the next 25 minutes or so is the current situation of COVID-19 in India. The vaccine, what are the principles and evidence as far as vaccine is concerned? Because when we talk of beyond the booster, it's important to understand the basic philosophy behind vaccine, where we are as far as vaccine rollout is concerned, the challenges that we have, and the solutions that we may be able to offer subsequently. So COVID-19 has resulted in the biggest pandemic of a lifetime. It started off with what was reported as a severe acute respiratory syndrome caused by coronavirus 2 in Wuhan, China in December 2019. And in the subsequent 2.5 years, it has infected at least 634 million people worldwide and has caused more than 6.6 million deaths. In India, we've had 3 waves. The second wave has been the devastating wave that we've seen. And in terms of number of cases and number of deaths, India has the second highest number of documented cases at 4.46 crores and the third highest number of deaths at 4.29 lakhs. But if you were to look at this in terms of the number of cases or number of deaths per million population, India has done remarkably well as compared to even the Western world. So the number seems large because of the size of our population. But if we look at it per million population, we've had much less number of cases and even the mortality has been less. We started off in January of 2020 when we had these first report of 3 medical students who had returned from China and had gone to Kerala, and they had actually traveled through multiple airports who came out to be positive. There was a lot of contact tracing done at that point in time. In March 2020, we had a lockdown, and the first wave we had in September of 2020, which had about 90,000 cases a day. We were very aggressive in launching our vaccine. We had 2 vaccines which were launched on the 16th of January 2021, and in less than 1 year of having our first case, and almost aligned with the vaccine launch as far as the Western world was concerned. We had a devastating wave of more than 4 lakh cases a day in March to May of 2021. This caused a lot of mortality. And then we had the Omicron wave last year in December, and now we have seen the end of the wave. So now we've had these 3 waves. And if you look at the current situation, we're in a pretty good situation that although we are seeing new variants, and it's been said that there are more than 300 variants being reported, which are all sublineages of Omicron, the cases are still there, but the mortality and hospitalization is very, very low. So let's go to the principles of vaccine and what is the evidence. So how do vaccines work? Vaccines induce an immune response of a host against a pathogen without exposing them to the disease. So they cause an immune response and without the person actually having the disease. And we have had more than 60 candidate vaccines for this just one virus undergoing human trials and more than 180 preclinical trials. They can work in various mechanisms. And I think this is important because sometimes people say that I got COVID and therefore the vaccine is not working. So vaccine can work in preventing infection. That would be ideal, that you have a vaccine which doesn't, which protects you in such a manner that you don't get the infection at all. But more often they work in preventing illness, that you don't get significant illness. It prevents hospitalization, it prevents intensive care admission, and it prevents death. So this seems to be the major role as far as vaccines of COVID is concerned, that they prevent significant degree of disease. You may still have a mild illness, you may still be infectious and transmit the disease to other people. But it can also help in preventing transmission because the number of people infected, if they are less, or the duration of infectivity comes down because of vaccination, then the transmission chain is also broken. So this is important to keep in mind as far as the action of vaccines is concerned. We have a whole array of vaccines now, and we have the inactivated vaccine. The Bharat Biotech vaccine is an inactivated whole virion vaccine. We also have live attenuated vaccine, although not very popular. The viral vector vaccines, which are available both as far as Covishield is concerned, the AstraZeneca vaccine uses a viral vector. So does the Chinese vaccine as far as viral vector is concerned. Then we have the nucleic acid vaccines, the mRNA vaccine, and the DNA vaccine, which is from India, the DNA plasmid vaccine. And then we have the protein-based vaccine, the protein subunit, or the VLP, the virus-like particle vaccine. So what does all of this mean? So when you look at the weakened virus, and this is basically the Codengenix by the Serum Institute of India, which is basically a virus. It is inactivated. It is a live attenuated vaccine which is used, which is a virus which is used as a vaccine. And then we have the inactivated virus, which is basically vaccine which are rendered non-infectious using chemicals such as formaldehyde, and they are then made inactivated like Covaxin or Sinovac. The nucleic acid vaccines are the one which created a lot of excitement because it was felt that they could be easily changed quickly modified in case we had a new variant coming, and they were easy to manufacture. And this was the first time that these came into the market and were allowed for human use. And in this vaccine, the nucleic acid is inserted into the human cell, and this produces copies of the virus protein. Most of these vaccines actually look at the spike protein and can be an RNA and DNA based vaccine. And very quickly, the RNA and DNA based vaccine disintegrates and does not really get involved into the genetic makeup of individual. The RNA vaccine we all know are by Pfizer and Moderna, and the DNA vaccine is the COVAX-D, which is the DNA plasmid vaccine by Zydus Cadila. Then we have the non-replicating viral vector vaccines, which are the Covishield, which uses an adenovirus. Covishield uses a chimpanzee adenovirus. It's a non-human adenovirus, which is the viral vector. The other Sputnik uses a human adenovirus vector as far as the vector is concerned. And we have the replicating viral vector vaccines also, which is like the weakened measles vaccine. Protein subunit vaccines came later on, and these were the VLP, the virus-like particle, or the protein subunit vaccines, which are protein subunits, which are basically at the virus spike protein. And this is the key part of it, which is at the receptor binding domain. And these vaccines may require an adjuvant to really stimulate the immune system. And Novavax or even Cobrivax, which is now available in our country, is a protein subunit vaccine. Again, the advantage is that one can rapidly produce large quantities of this vaccine at a very low cost. So vaccines have undergone a number of clinical trials, and the whole issue comes up, and this is something which will always be there, that when we come with new vaccines, should they undergo all of these new trials, especially when you're looking at beyond the booster dose and with new vaccines. So we have preclinical trials, phase 1 trial, phase 2 and phase 3 trial. Preclinical, we all know, are basically on animals and primates. Phase 1 are on healthy volunteers, which are basically looking at dose ranging and safety, immunogenicity. And then phase 2 and phase 3 sometimes are combined, basically to look at immunogenicity, safety, and look at a real life situation. What we've been able to do in the last, during the pandemic, was we've been able to compress all of this and work in sequence rather than parallel. It would take us almost 10 years to get a vaccine, because the fact that it underwent various stages. You had first preclinical trials, and then you took a decision whether this vaccine was worth taking forward. You had the first human trials, efficacious trials in humans, and evaluation trials. All of this was compressed with a lot of investment being done and risks being taken, so that once you had a target vaccine, it went into clinical trials, and production also started simultaneously. While the trials were being done, scaling up was being done as far as manufacturing is concerned, and very quickly approvals could be given and vaccines could be manufactured. Because of this, we were able to have a large number of vaccines within 1 year. Now, with this data which we already have in terms of the preclinical phase 1 and phase 2 trial, it would be easy to move ahead in terms of new vaccines beyond the booster, if we are looking at that, because the basis of the safety and efficacy is already established as far as this is concerned. And we do this for the influenza virus. We every year have an influenza vaccine, which is basically a new vaccine, but at the same time, these phase 1, phase 2, and phase 3 studies are not really required, because the basics safety and efficacy and immunogenicity studies have already been done. Now, the great question that comes up is, what should be a vaccine efficacy for a COVID-19 vaccine to be licensed? And we all know that vaccine efficacy is equal to the attack rate in unvaccinated minus the attack rate in vaccinated divided by the attack rate in unvaccinated and multiplied by 100. Now, each of the trials, and that is where the tricky part comes, each trials had a pre-specified number of detected cases for which efficacy was to be assessed. And this led to the calculation of the sample size and how many individuals were required. The US FDA and WHO has provided some degree of guidelines in terms of minimal efficacy, and efficacy should be at least 50%. And lower bound of the confidence interval should be at least equal to more than 30%. However, it's also important that studies should assess severe COVID-19 as an additional endpoint. And this is also something that we should keep in mind. Because if you remember, like I said, we're all looking at efficacy through multiple parameters: infection, severity of illness, mortality, and transmission. So this is something that we need to keep in mind as we move ahead. If you look at the initial data, most of the data which came out with the first few vaccines showed that the protection that they were giving was up to the tune of 94% to 66%. And all of them required more, usually required more than one dose. So this was something that we need to keep in mind in terms of the efficacy, but this has waned over a period of time. Just briefly touching on COVID-19 vaccines rollout in India, because I think this is something which is remarkable and something which will help us if as we move forward in the vaccine program, if we need to give doses which is beyond the booster dose. So in April of 2020, there was formation of the National Expert Group of Vaccine Administration, the NEGVAC. We were all involved in this. We really had multiple meetings, and states were asked to set up state-level mechanism for vaccine program, including cold chain. Remember, if you have to give so many vaccines in adults, you have to be able to maintain a good cold chain, otherwise the efficacy of the vaccine will not be there. In November of 2020, the COVID Suraksha mission was launched with rupees 900 crore being given to DBT for development of COVID vaccine. A large amount of money was given in the budget, and we had both Covaxin and Covishield launched in January of 2021. And I think now we have a large number of vaccines. The issue really is that are they effective now with new variants coming in? We have Covishield, Covaxin, Sputnik, Johnson & Johnson's vaccine, the ZyCoV-D, and CobraVax has also been approved. So all of these vaccines are available in our country, and most of the data suggests that they are still effective in terms of severe disease, and I'll just come to that. CobraVax is the latest vaccine to be added. This is a protein subunit vaccine, contains a version of the receptor binding domain of SARS-CoV-2, a spike protein, and this also has an adjuvant. This was initially developed by Texas Children's Hospital and Baylor College, and then were licensed to Biologically, which was an Indian company. And this is a very cost-effective vaccine, has also been now approved and deployed in children. There's also data which has come up, although not published that much, which suggests that if we were to give a heterologous vaccine, that if you took your previous Covaxin or Covishield and subsequently took the booster dose with Cobrivax, the immune system was better stimulated as compared to taking the same homologous vaccine as a booster dose. If you look at the current data, over 2.19 billion doses of the vaccine had been administered in India, and 70% of our population is fully vaccinated, and we have surplus doses as far as the vaccine is. And currently, we are actually not facing a shortage of vaccine. There is a huge concern about the vaccine actually, the date expiring, and we're not having to destroy some degree of vaccination because we've been able to produce more vaccine than what we need. There have been a lot of efficacy data. This was the initial study which looked at the safety and efficacy of the AstraZeneca vaccine, which was Covishield, looking at Brazil, South Africa, and UK. And this actually showed an overall efficacy of 70% with 2 doses 28 days apart. And there were cases of transverse myelitis also reported while the study was done, but the overall efficacy was good, up to 70%. Similarly, when we looked at the inactivated SARS-CoV vaccine, which is Covaxin, the efficacy was 77% as far as the Indian Bharat Biotech vaccine was concerned. And this was also highly effective against laboratory confirmed symptomatic COVID-19 patients. This is a study that we had done, which was done by us during the Delta wave, which we looked at the effectiveness of this whole viron vaccine, the Bharat Biotech vaccine. It was a test negative case control study. And here again, we were able to show that the vaccine was effective if 2 doses were taken. And the efficacy for symptomatic COVID-19 was up to 50%. And this helped in confidence building as far as the rollout of the vaccine was concerned. We subsequently did another study where we looked at reinfection rate and estimated efficacy, and this was done subsequently, where we tried to look at the efficacy of healthcare workers who had taken Covaxin, and a protection associated of 86% against reinfection was observed among healthcare workers who completed the 2 doses of the scheduled Covaxin vaccine. We also then had the INSAGOG, the Indian SARS-CoV-2 Genomic Consortium, which started off with just 10 laboratories in January 2021, and now we have more than 50 laboratories which are doing genome sequencing. And this really helps us to pick up the variants, and the data is then fed into the NCDC website, where the clinical factors are also looked into, and therefore we get a clinical epidemiological idea regarding how the new variants are behaving, and is the new variant a cause of concern. This was what happened way back in 2021 when the B1617 lineage was reported. This was at that time called the double mutant because it had mutation at site of E484 and L452. A variant belonging to this lineage became what was known as the Delta variant, the B16172, and this was declared a variant of concern, and this caused a huge number of cases and deaths because this was highly transmissible and attacked the lower respiratory tract, leading to viral pneumonia. So I think the importance here is that we need to have aggressive genomic surveillance in our country for new variants and combine that with clinical epidemiological data so that we're able to see how are these new variants behaving. Are they causing more severe disease? Are they behaving in a different manner? And therefore, that will help us to decide a treatment and vaccine strategy for the future. So what are the challenges and solutions? So vaccine protection against SARS-CoV-2 infection does wane over time. It does protect against hospitalization and death, but also wanes somewhat, and that is something that is a cause of concern. A recent study published in JAMA in October looked at the statewide data from North Carolina, which included over 10 million adults, and it had showed the following results. And we started looking, they looked at protection against infection, against hospitalization, and against death. And they looked at a vaccine effectiveness at 7 months and 12 months. Now, this is recent, and therefore this covered some of the new strains also. And what they found was that against infection, the efficacy fell down to almost 38 to 47%. Against hospitalization, it came down to around 60 to 65% from 86 to 90%. And against death, it came down from 90 to 93% to 70 to 75%. So waning immunity, but not more significant against infection as compared to death and hospitalization. And that is something that we need to keep in mind. What are the variants and why are we concerned about them? Because this is an RNA virus, and we know that RNA viruses will continue to mutate. It's been estimated that SARS-CoV-2 will mutate at least twice a month. And therefore, these mutations usually have no impact as far as viral function is concerned, and they are only what is known as variants of interest. But we do have variants of concern, which actually are behaving in a different manner. A variant of concern is a variant which may have developed increased transmissibility. It is causing more infections. And most of the recent variants of concern that we have picked up are causing more transmission. It may have ability to evade immunity to previous variants. And this is another thing which leads to more cases, because most of the new variants are developing immune evasive ability. And therefore, they are infecting people who already have had vaccine or previous infection. However, the current variants of concern are not causing increased disease severity. If that does happen, then it also becomes a variant of concern. So, and the fourth factor here, which makes it a variant of concern, is if the variant becomes, a mutation occurs in such a way that the RT-PCR test is not able to pick it up because of the variation that has occurred. So variants of concern are basically these four: increased transmissibility, immune escape mechanism, more severe disease and hospitalization and death, and being missed by the routine RT-PCR test which is being done. We've had these various variants of concern. I won't go into this because we've already gone through all of this in the last 2 years. The alpha variant, the beta variant, the gamma variant, which was predominantly in Japan and Brazil, and of course the devastating Delta variant, which started off from India but caused a huge number of disease and death as far as the world is concerned. And then in November of 2021, we had Omicron. The interesting thing about Omicron is that the new sub-lineages that have come are all lineages of Omicron. There has been no lineages from the Delta variant or the previous variants, and Omicron seems to have become now the circulating dominant variant globally. And whatever variants that we're seeing, sub-lineages, are actually coming from Omicron itself, which in a way is good because this is a variant which is causing milder disease, unlike what Delta variant was doing. It was a cause of concern because there were over 30 mutations in the spike protein, and therefore, even without a lot of data, WHO declared it a variant of concern because they had never seen so much of mutation occurring in the spike protein of the virus so quickly. It causes increased transmissibility and decreased susceptibility to the neutralizing antibodies. And as we have seen, that new variants have emerged, but data suggests that vaccine remains effective in preventing severe disease, but effectiveness in preventing symptomatic infection is attenuated, and we continue to see cases of COVID-19, but predominantly like a flu-like syndrome. How does the vaccine work? And this is a study which was published in March in the NEJM. And when they looked at the Omicron variant and the Delta variant, what they found was that with Omicron variant, the vaccine effectiveness, even against the mRNA vaccine, came down rapidly. And by 25th week, it was actually very, very low. But with the booster, it went up significantly as far as mRNA vaccine was concerned. The paper also looked at the AstraZeneca vaccine, Covishield. And again, if you see, as far as the Omicron variant is concerned, around the 25th week, the vaccine efficacy is almost 0%. But with the booster dose, it comes up significantly and is able to provide good protection against Omicron variant. And therefore, even with the sublineages as far as Omicron is concerned, the booster will provide protection as of now. We can also tweak the vaccine to cover new variants. This has been a concern about immunologists, that the efficacy of the vaccine will wane, because after all, the vaccine that are currently being provided are the basic origin is from the Wuhan strain. And we have moved way ahead from the Wuhan strain to the Alpha, Beta, Delta, and Omicron strain. But vaccines can be tweaked to overcome this problem. And we do this every year as far as influenza vaccine is concerned. We have the Northern Hemisphere vaccine, which is a quadrivalent vaccine, the Southern Hemisphere vaccine, which is a quadrivalent vaccine covering 2 influenza A and 2 influenza B strain. We started with the trivalent vaccine, but since influenza B started becoming dominant and there were 2 strains rather than 1 strain of influenza B becoming dominant globally, WHO changed the guidelines and a quadrivalent vaccine has been there for the last few years. So it is possible to really tweak vaccines as we move forward to cover the circulating strain. And I think this is how things are going to be in the future. Influenza mutates at a faster rate than SARS-CoV-2, and therefore tweaking should be possible. For influenza, the virus is isolated, the new strains are isolated, grown in culture, inactivated, and then the vaccine is prepared. For mRNA and DNA virus vaccine, this is easier to do, to modify, and therefore tweaking viral vector vaccine is also possible. So I think with the new vaccine platforms that I showed in the beginning, it is easier for us to change or tweak the vaccine than what was there in the past, and this should be something which should be possible. And this has been done. This is a paper which has just come out in October in NEJM, which looked at the bivalent Omicron vaccine, which contains the booster vaccine against COVID-19. And they looked at the booster doses with bivalent. So this covered the original strain and included the BA1 spike protein as far as the Omicron subvariant was concerned. And what they found was that when they looked at the neutralizing antibodies against the ancestral strain, that is the D614G strain, they found that on day 29, with all participants, those with no previous infection and those with previous infection, the booster dose gave good amount of immune response in terms of neutralizing antibody. Also, when they looked at the Omicron variants which are circulating, again, the booster dose gave a good amount of neutralizing antibodies with both the RNA vaccines, and therefore showing that now with the bivalent vaccine, we should be able to provide protection even against new emerging strains. And it's felt that the new vaccine that may come will be able to cover most of the lineages that we would see as far as Omicron is concerned. This actually led to the CDC now recommending that all individuals more than 5 years old who have completed a primary COVID-19 vaccine series should receive a single booster dose with one of the bivalent vaccines at least 2 months after the last vaccine dose. So this is an FDA emergency use approval for both the Pfizer bivalent booster dose and Moderna bivalent booster dose. We need more data because there are also studies which suggest that currently our immune system is pretty well tuned to as far as the immune response is concerned from previous infections. And like I said, COVID-19 is becoming more and more endemic. Many people are having a flu-like syndrome, and when they do a rapid antigen test, they come out to be COVID positive. So we are also developing our own immunity due to natural infection rather than by vaccination. And that is also providing protection in terms of herd immunity and protection to the population. So what are the challenges and solutions, and how can we work on this? There are other issues that we need to look at beyond just the bivalent vaccine. And I think the first issue is to have equitable distribution, which is very, very important. Because currently what we can see is equitable distribution is not there. Vaccine distribution is much more as far as high-income countries are concerned, and this will avert cases and deaths to a much lesser amount as compared to if there was equitable distribution. And equitable global supply and addition of is our best to end the pandemic. No one is safe unless everyone is safe, and this is something which has been said from the very beginning. And if you look at the current data, you will find that most of Africa, the coverage is less than 20 to 30%. That is that many countries in Africa have still not vaccinated even 10% of the population. So although the Western world has got 80% plus vaccination, India has achieved around 70%. We have a large part of the world which is not vaccinated fully, and here there is a chance that the virus here can continue to mutate, develop new lethal strains, and then this can spread to other parts of the world. So I think it's important for us to really look at vaccination as a global responsibility rather than just as a national responsibility. Vaccine hesitancy, another thing which has come up and become even more now. Initially, when it looked at COVID-19, and this is an old paper from the National Medical in 2021, which suggested that India, 75% of people said that they would take the vaccine if it was proven to be safe and effective. The main reason for not taking the vaccine were concerns about its side effects and safety and lack of trust in the process. And younger people and those from low socioeconomic status were likely to be hesitant. But this has gone up significantly. And I noticed that in my OPD and my clinic on a daily basis, that most of the people who are at high risk, many of them have not taken the booster dose and have this feeling that it has more side effects, and currently COVID is no longer a cause of concern, and therefore they don't need to take the booster dose. I think we need to address this issue also, because as WHO said, vaccine hesitancy is one of the most common, it has become a common worldwide global threat, and that is something that needs to be addressed. It's a major obstacle in achieving vaccination coverage, and we have to address this issue by really making direct recommendations for vaccination, identifying concerns, educating patients, and dispelling misconceptions about the disease and vaccine, because still a large number of people are vulnerable and they do need to take the booster dose. Unless we do that, we can't move beyond the booster dose. The major lessons for COVID-19 is that this century is going to be a century of outbreaks and pandemics. In the last 22 years of this century, we've had SARS, we've had MERS, we've had H1N1 pandemic, COVID-19 pandemic, Zika outbreak, H5N1 bird flu outbreak. In the south, we had Nipah virus outbreak, and then we have the monkeypox and the tomato flu also coming up. So we need to really prepare for outbreaks in the future and really educate people on non-pharmaceutical measures, as they are still important, work aggressively on new vaccines and drugs, and need to safeguard non-COVID or non-pandemic diseases also, because they also suffer a lot. During the COVID pandemic, a lot of non-COVID diseases suffered, and many patients actually suffered because of limited care as far as non-COVID care was concerned. This is an article I had written way back in 2018, 100 years after the flu pandemic, that was the 1918 pandemic. We were still vulnerable, and with the current outbreaks, we needed to be vigilant and really develop a good system for outbreak management. Unfortunately, I didn't really think at that point in time that we would have a pandemic in the next year or two. But I think this, as we move ahead, we need to keep this in mind, even in terms of for subsequent vaccine development. So to conclude, COVID-19 vaccine prevents infection, hospitalization, and deaths. And current data suggests that the current vaccine also are effective to some extent, although there is waning immunity and protection increases with passing time and emergence of new variants. But current evidence for booster dose is primarily from the mRNA vaccine, and we need to look at newer data which is coming from various studies in our own country, looking at the newer vaccine which covered the emerging variants. Bivalent vaccine induce antibodies against the newer variants and provide better protection. But I think there is a need for global commitment for equitable vaccine coverage worldwide to tackle vaccine efficacy. So I'll stop here, and I will be very happy to take any questions if there are so.
நீ பிள்ளைகள் எதுக்கு சொல்லு
Thank you very much, sir.
Thank you, sir. It was an excellent presentation. And I think you have answered most of the questions. But now one important thing which you have said, we can tweak the message like flu vaccine. I think that will be the order of the day, I think. Here afterwards, we'll have yearly once we should take COVID vaccine. That's the solution. And now I heard from Singapore, they have had XBB vaccine also. I mean, XBB strain, which is more dangerous. Do you have any idea about that?
Yes, so XBB strain has been reported in Singapore, and they have reported more hospitalization. XBB strain has been reported in India also by the INSAGOG. But what they've said is that in India, they've not found any increased hospitalizations wherever the XBB strain has been reported. But definitely it's a cause of concern because this is a recombinant variant which has emerged. That means two viruses of different variant have sort of infected the same person, and a recombinant virus has emerged. So there is a concern that this may cause more severe disease. Singapore is reporting more hospitalization, and that's why we need to be very careful.
Yes, sir. I think now over to Manjula for any other remarks.
There is a question, Dr. Vidya Sundaresan. Madam is asking, role of wastewater surveillance in India for predicting emerging diseases.
Yes, Dr. Andip, Vidya Sundaresan is from US, your old student. She's now settled in Chicago. He's an infection specialist. It's Vidya Sundaresan, my good friend.
Okay, very nice to have her on this talk also. Yes, sewage surveillance is very, very important. India has started a program, and in many cities, including Delhi, Mumbai, there is a regular surveillance which is done of sewage sample. And what has been shown is that you can pick up a new variant almost a week to 10 days before it is clinically picked up by looking at sewage samples. But these are dead viruses, but you can pick that up, and increase in the viral load in sewage also is helpful. So this is now becoming a standard practice, and there is a lot of push by DBT, Department of Biotechnology, to develop a standard protocol for sewage sampling for picking up new viruses and new strains from major cities in our country. I think that data will be encouraging, and it will help us it will give us a little bit of lead time before the cases become more rampant as far as clinical cases are concerned.
Dr. Manjula?
Yes, sir. Thank you very much, sir. Yes, sir. Please.
If I can ask a question?
Yes, sir. Please go ahead, sir.
Go ahead, please.
Sir, excellent talk. Thank you very much. Just one question. Why has the still children not been aggressively given the vaccine? Because again, these are a huge population who are likely to probably, breed mutants if they are not vaccinated.
I agree with that. So initially, children were not targeted not given vaccination because data was not there, safety and efficacy data, which is now available even for children up to the age of 5 years. Vaccine can be given, and even the Cobravax vaccine has been approved for children above 5 years. We need to work aggressively in, like you said, addressing the issue of vaccine hesitancy. It is approved, but children are not coming forward because of the concept, the thought process that is there among some physicians, which is true to some extent, that it causes milder illness in children, and therefore children need not worry. But that is not the only thing. As you rightly said, if children get infected and a large number of them get infected, they can serve as a reservoir where there can be mutation and new variants can emerge. Secondly, children carry the infection with them to their houses, and they can then infect the elderly in the house or the grandparents. and they can get more severe illness. So protecting children or immunizing children helps in many ways. And this has been shown in studies there was a study that we did in Ballabgarh, where it was shown that if you vaccinate children, the infection among adults, especially older generation, also comes down because the infection is taken to houses by the children. So I think aggressively we need to work on vaccinating children, and I hope that it will become part of the national program in the near future. But currently there is a little bit of vaccine hesitancy among parents as far as vaccinating children is concerned.
Thank you, sir. Thank you so much.
I think, thank you, sir. Thank you very much. The whole program will be on the website, and we'll also give the recordings for those who have not attended. Once again, thanks, Professor Randeep Gloria, sir. Over to you, Manjula, for the next.
Thank you very much, sir. Dr. Randeep, sir, it was wonderful. I know you're so busy, still you could come and join us, and really we are indebted to you, sir. And Dr. Muruganathan, sir, thank you very much for supporting us and guiding us, in fact hand holding us and doing the whole thing. Thank you so much, sir. Now we move on to the next session, which is artificial intelligence in healthcare, which we are all also looking forward how it is going to change our patient outcome and our practice with the machine learning models. So to chair this session, I request Dr. Jagdish Channappa, sir, to chair this session and conduct the procedure. Over to you, sir. Please, I don't want any CV of chairpersons. Only put Dr. Ravi Ramaswamy CV, please.
Thank you very much, Dr. Manjula, for asking me to chair this extremely important session. We all have been used to using our brains for thinking, but now that is going to be replaced by machines which are going to do the thinking. And this is a scary thought for at least me. I don't know how most of us other people will react to it. And I think it's a very nice thing that the Fever Foundation has thought about this unusual topic, because this is normally not discussed in the medical fields very often. So to talk about this, I invite Mr. Ravi Ramaswamy. He is the Chief Executive Officer at RV Consultants, former Senior Director and Head Philips Health Systems, former lead GE Healthcare. He has been on several incubators, startup and educational institutions, coaches and mentors, senior leaders in ecosystem, and he has phenomenal 3 decades in healthcare space, and also a task force on several government communities, and is a fellow of the Institution of Engineers. And I think he's got a huge biodata and a very senior respected consultant. So I invite him to start his deliberations today.
Dr. Jagdish, thank you so much for this kind introduction. My sincere thanks to the Fever Foundation and to Dr. Manjula Suresh for sort of giving me this opportunity to share my 2 cents on the role of AI in the healthcare space. I would like to share my screen, please. Are you able to see it?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So basically what I am going to touch on is the need for artificial intelligence. What is AI and how is it built? Just give a top level synopsis of what this is all about. What are the different types of AI that we get to know? Where are the possibilities where we can deploy AI? And of course, in conclusion, saying, does the most often asked question saying, can AI replace paramedics and doctors, is something that I would also want to touch upon in my conclusion. With that, if we really look at the global healthcare challenge, we find that 1 out of 3 people will be diagnosed by cancer in their lifetime. 500 million people suffer from respiratory diseases. 400 million people have diabetes, and an estimated 1 billion adults are expected to have hypertension. The demand for care is always going to grow, and the shortage of healthcare professionals will also increase exponentially. According to the United Nations, the world's population is expected to increase by 1 billion by 2025, And out of that, 300 million people will be 65 years or old. If we push that into 2050, we find that there will be almost 2 billion people over 60 years of age, and about 390 million people will be 80 years of age plus. The Brookings Institute also estimates that about 65% of the global population will be in the middle class by 2030, who will be demanding quality care. The world has a shortage of 12.9 million healthcare workers by 2035, and today that figure stands at 7.2. If you look at the spending, US spends 17% of its GDP in healthcare, and EU spends 10% of its GDP. Now, if you look at the magnitude of the problem that these are problems that are of significantly high intensity, and a normal tactical solution of what we have been doing so far is not going to help us. If we really look at this photo, which I shot in Shanghai, you find that the number of people, this is an OPD clinic. It reminds me of Dr. Guleria's All India Institute, where we have almost 10,000 patients a day. This is a case in China where you find that the number of patients is significantly large. And number two, what is more worrying is that the age of the patients is coming down. You see a lot more younger patients out there, which is a cause of concern. So if we really look at it, what are the challenges that we are having in the healthcare world? One is availability, that is lack of adequate infrastructure and skilled personnel to deal with this problem of this magnitude. Accessibility, we also talked about it. In fact, Dr. Guleria touched on this unequal distribution of care, which is so prevalent, not only in the vaccine, but also in the healthcare ecosystem. Increasing cost of care and affordability, given the fact that even in places like India and other developing geographies, a lot of it is out-of-pocket payment. The insurance has not penetrated the way we get to see in a Western world, is also sort of driving family to bankruptcy. Awareness, delay in early diagnosis, and of course, chronic diseases and the lifestyle diseases are on the rise. So when you look at the macroeconomic factors, you find that the conventional approach to solve the problem is not going to be helpful. Increasing the hospital beds, increasing doctors, increasing nurses, increasing the spend in GDP is not going to really help us. I think we need to look at methods wherein we can do more with less. And that's where exponential technologies actually come in. I was surprised when somebody told me, saying that when you walk across the room and you take 30 linear steps, you move from one point in the room to the other point. Whereas if you took 30 exponential steps, you would be walking around the planet 26 times. You know what? I actually did this calculation to ascertain to myself that this is indeed true. And lo, it was the fact. So what we really need to look at is exponential technologies which can help solve the problems, which otherwise is going to be very, very difficult in dealing with problems of these magnitudes. So one of the exponential technologies that we are looking at is artificial intelligence. What is artificial intelligence? It's basically a combination of artificial and intelligence as applied to machines and not to humans or any other animals for that matter. So if I sort of just read this out, artificial intelligence is that exhibited by machines rather than humans. It defines it as a study of intelligence agents, any device that perceives its environment and take actions that maximizes its chance of success in a given system. So what we are now trying to do is trying to use machine and the computational power that is now available to see how we can dispense care and take it to the next level of success, so to say. So when you look at artificial intelligence, what are the common assets that one gets to look at? It could be imaging data. It could be waveforms like what we get to see in an ECG. It could be clinical notes and prescriptions. It could be critical care monitoring data, which comes out of a critical care monitor, or it could be the pathology. It could be the slides and the data that goes along with it. Add to that the genomic information and the molecular information. So this is basically the whole AI. These are basically the assets that are available to us based on which we could make diagnosis. So if we really look at a life cycle at how is an AI actually developed, there are multiple things that we need to appreciate here. First one, there is a volume. Volume is something that we look at, which is basically the scale of data. You look at the velocity, saying how often and how much of data is actually coming into the system. The variety of data that we looked at, it could be an ECG report, it could be a EMR record that comes in, it could be the contraindications, it could be the biogram, which talks about the susceptibility to antibiotics. And on top of this, there is also a certain amount of uncertainty in the data that comes in, which is called as the veracity. So basically what we do here is we collect the data is curated. That is, we ingest the data, we clean the data, understand that we are able to sort of create some ground rules for it. Then there is what is called as a feature extraction, which is basically feature creation, feature selection. And we also use the clinical domain expertise to try and understand what it takes to build a particular algorithm. Then you use the data modeling and the validation, which involves machine learning, which involves deep learning, compute intensive training and iterative training and stuff like that. And then once the model is developed, you are then able to sort of take it for clinical validation to see if it really serves the intended purpose and take it through the CE process, the FDA process, just so that you are sure that it conforms to all the regulatory needs. And then the best way is to sort of then take it and integrate it into the hospital workflow in order to assist the doctors and the caregivers in terms of easing out which is basically the intended purpose of the algorithm. So this is basically how an algorithm actually gets developed. Typically, we find that a bulk of the time is spent in cleaning and preparing the data, and then an equal amount of time is spent in validating the data. Like 45 to 50% goes in preparing the data. You've got about 20 to 30% in validating the data, and then about the last 10% is on integration. So developing the algorithm per se is only 1/3 of the process. The balance 2/3 is about how do you collect the data and how do you sort of validate it. There are different types of AI solutions that we get to look at. Let's start with the descriptive analytics, which is basically saying it will tell you, study the data from the raw data and describe what has actually happened. The next step towards measuring the technology is called diagnostic analytics, which basically tells us, saying it compares the coexisting trends of movement, uncovering correlations between variables, looking at causal relationship, and answers the question, why did that event happen? Then you get into predictive, which says what might happen into the future, and the prescriptive, what should we do next to prevent any of this from happening. So even in the analytics, in the world of analytics and AI, there's an evolution that we get to see. At this point in time, I would dare to say that we are more looking at the descriptive analytics and diagnostics. In some cases, we are far away from preventive and prescriptive analytics in that sense. We also look at, there are multiple data that comes up, which is called as deep data, wide data, dense data. People talk about it all the time. Like, for example, let me give you some examples. When I look at an MRI or a CT scanner, which has now become digital, we can obtain much sharper images that gives us detailed information than ever before. Today, we can unleash the power of managing health at a population level by virtue of dense data. We can perform risk stratification on population level and implement preventative health programs for those at risks. With a vast amount of data, we can also do pattern recognition via machine learning and apply this, like, for example, in home monitoring or ambulatory care and ICU, where we can use and create preventative programs or therapies. And we also talked about working on personalized care plans that picks up abnormalities at a very, very early stage. These are the typical application of what a dense data can actually help us. And we also looked at wide data, which talks about new personal measurement devices, mobile diagnostics, sensor technologies, by which you are able to sort of look at a particular data set over an extended period of time, continuous monitoring over time, what we look at longitudinal records, and then draw inferences as to why it happened and what is going to happen. So if we look at the AI trends in the healthcare world, we talked about this, and this was also opined to by my earlier speakers. We talked about personalized treatment plan, where you can treatment plans which are being customized by machine learning systems based on patient medical condition, their past history, and a specific need for improving efficacy. You could look at preventive treatments which are based on AI platforms and a patient medical history, along with environmental factors who are highly susceptible for developing illness, and therefore recommend treatment programs to them. Improved diagnosis, which are able to detect anomalies and with enhanced accuracies. You are able to sort of pick up the disease well before it actually manifests itself. And then you're looking at automated diagnosis, where technologies are being integrated into the diagnostic device for automating simple medical tests, which can be done without human intervention, relieving medical professional of non-core activities. Take, for example, the smartwatch, the Apple smartwatch. You can pick up a ECG, a 2-lead ECG equivalent out of it, and if you have fibrillation, there is a way by which you could alert your caregiver on saying that, yes, there is going to be a part of saying that I'm undergoing certain challenges, and it can contact your doctor, and a doctor respond back to you instantly without even you realizing that somebody has reached out to you on your behalf. So there are technologies that sort of help you dispense care automatically in a scenario where otherwise it could have been a life-threatening situation. Now, if you look at, like, for example, we always talk about cost, quality, and access. These are known as the iron triangle in healthcare, because once you try to optimize cost, you realize that your quality and access can get impacted. If you try to increase access, your quality and cost gets impacted. And if you try to increase quality, then you have got an impact on the others. And that is where solutions like artificial intelligence can actually come in and sort of support you. Take the case of virtual radiology. Suppose if I have a scanning center, say about 100 kilometers off in Chennapatna, a technician can take the scan out there, push the scan into the net. The first level of diagnosis can be done by the AI tools, and at least do a first level of screening, saying, is it good, or is there a problem? Is it okay or non-okay? Is it normal or non-normal? Once that is ascertained, if it is a non-normal, it can then route it to the next radiologist who is available on the system, who can then report it out and get back to the clinic where the scanning was actually done with the report, and the entire turnaround time can be done in 45 minutes. Now, so basically what we are trying to do is, we know there's a shortage of radiologists in the country. We looked at that in the earlier slides. What we are now trying to do is to use the capability that exists in the cities to dispense care into the rural area. It is a typical hub and spoke model. So by doing so, you are ensuring that the one at the remote site gets the same quality of care as one who would have got in a premier a corporate hospital in any of the metros. That's one way. AI can significantly reduce healthcare costs to use of self-assessment tools, which can eliminate unnecessary inpatient doctor visits. The platforms can monitor patient at higher risk of readmission, and in turn facilitating significant saving on the cost of care for the healthcare providers. There are systems which can predict disease in its early state, providing more accurate patient risk stratification and identifying a proactive course of action to treat them, thus bringing in new precedent in the quality of care provided to the patient. So there are multiple ways by which AI can help us solve the tangle that we are in terms of optimizing cost, quality, and access. We talked about patients with chronic conditions to self-manage. This is something that, thanks to Philips, we actually have this live, and we have actually deployed it, by which patient with, say, a type 1 type 2 diabetes, we are able to use algorithmic detection to manage, look at their consumption, look at their insulin levels, and look at their activity level, the nutrition that they put in, and together come up with a treatment plan, and also advices and coaching And consequent to all of this, we find that we are able to reduce the cost of care by 26% and readmissions by about 52%. There are evidences for this, thanks to Philips. There are imaging-enabled products like, for example, we can do brain anatomy segmentation, that is delineation of anatomical structures of brain with volumetric images. We could do brain tumor segmentation, that is detection and segmentation of brain tumors from multimodal MRI scans. Cardiac MRI segmentation for segmentation of cardiac structures. Bone assessment, which is used in forensic science, wherein you can use the X-ray image for determination of skeletal age. And then, of course, you got the ligament tear detection for automatic detection of ligament tear in knee MRIs. And the list goes on. Adaptive intelligence can not only come in dispensation of clinical care, it can also come in the diagnostic side. Like, for example, how can I optimize speed? How can I enhance the patient experience? How can I do a more confident diagnosis? How can I bring in clinical efficiency into the system? And how can I drive operational efficiency? Like, for example, there are systems which basically keep looking constantly at the log of, say, an MRI or a CT or a cath lab, and looking at the parametric, the variations, they are able to predict as to if the machine is going to go down, and if so, on what account. And by doing so, you are able to plan your service well in advance, even before the machine shuts down. The other aspect is, like, for example, turning communities and homes into care settings. Dr. Devi Shetty keeps talking about this fact, which is so true, that at one point into the future, the hospital is going to be a place only for the ICUs. The balance of the care will be dispensed at home, because you have got so much of tools that are built into the devices and applications that are available around you, that the need to go and conserve the resource is done in a manner that the hospital beds is only used. The limited amount of hospital beds that we have is used only for ICU, and the balance of the care is done outside the hospital, because you also get far better outcomes given that you are being treated in a home environment. Of course, the patient monitoring at home and the care management at home also comes in, which is again which can be driven predominantly by the AI tools and the systems that we have. We talked about population health management, clinical behavioral and operational data analytics can be done to sort of stratify where the population risks are, which are the at-risk population segments, and what interventions can be driven to drive positive outcomes in a manner that we want it to be. The next one is around biophysical modeling, and what I really want to do here is not talk about it, but actually show you a movie.
Imagine a future where personalized healthcare will provide every individual the right type of care, in the right way and at the right time. A key enabler for this will be computational biophysical modeling. Let's look at an example of how this plays a significant role when Dr. Sullivan, a cardiologist, is treating Mr. Burke, who has been diagnosed with atrial fibrillation. Although AF is a highly prevalent disease, it can be complicated to decide on the individual treatment strategy for a patient like Mr. Burke. This is where biophysical modeling proves useful. It starts by using Mr. Burke's medical data to create a patient-specific biophysical model, including a virtual version of his heart, which looks, behaves, and reacts just like the real one. This biophysical model, combined with cloud data on similar cases, allows Dr. Sullivan to select ablation as the therapy with the best possible predicted outcome for Mr. Burke, both on the short and on the long term. Dr. Sullivan carefully plans the procedure by simulating various ablation scenarios on Mr. Burke's virtual heart model. She is then able to select the one with the optimal computed result. The chosen ideal scenario forms the basis for real-time intervention guidance. During the procedure, all taken actions, as well as any unforeseen situations, are processed real-time into the biophysical model to redirect if necessary. As a result, Dr. Sullivan could treat her patient at the right time, in the right way, with the best possible outcome. This is one of many potential cases in which biophysical modeling forms an essential building block for an optimal healthcare system. From personalized diagnosis and therapy selection to procedure planning and guidance tailored to the patient's physical characteristics, medical history, current condition, and future needs.
I come to my last slide, the oft asked question saying, can AI replace doctors? The answer is not. And this was also ascribed by Dr. Muruganathan, saying empathy cannot be replaced. There is no way, when you go to a physician, you look up to him a lot more than mere diagnosis and treatment. It's about hope, compassion, trust, expressing the feeling of understanding with an appropriate response, good counsel. These can never be replaced. Physicians have a non-linear working model. Let me sort of relate this case to you. There was a guy who was diagnosed with poisoning. They considered many different options: drugs, food poisoning, pesticide poisoning. Every possible diagnosis, they suggested different treatment options. Some of them made the patient worse. Then they figured out that the boy picked up a material called phosmet, a type of insecticide, from the genes that he brought from a street vendor, which was kept in a truck which carried fertilizer earlier. Any amount, the boy did not actually wash the gene, he just wore it, and through that skin absorption, he got poisoned. Any amount of AI will not be able to detect this. It does require a human brain working in nonlinear fashion to make this happen. Complex digital technologies require competent professionals. The brain is so complex that it might be futile, if not impossible, to recreate it. So let the brain do its job and let the machine do more of the repetitive stuff that it is more adept at. And it has always been a tech versus, it has never been a tech versus human. It is always a tech with a human combined that has so far made the difference for mankind. From even if we look back at the scientific advancement. So overall, suffice to say that what we really need to do is to AI enable the doctor rather than looking at AI as a replacement for the doctor. And with that, I come to the end of my presentation. Thank you once again for hearing me out and giving me this opportunity to share my 2 cents.
Thank you, Mr. Ravi Ramaswamy, for that brilliant lecture. And I think your last slide said it all. It is a brilliant slide, and we just enjoyed your talk. Thank you so much. We can allow one question if anybody has got a burning question.
So I'm Dr. Suresh. Can I ask one question there?
Yes, sir, please.
Yeah. So this is basically AI needs a lot of data. Unfortunately, most of the doctors we write in hand, and I don't know how it's going to help out. For example, in US, it's all electronic health records. Is there any good electronic health records? That's the first step for all technology to be useful to us. Any good electronic health records you are suggesting for an Indian system? Because a lot of available in US, a lot of available in other Western world. What do you suggest for Indians?
So even in India, if you really look electronic, previously I have been in the system for about 40 years, out of which 30 years I've spent evangelizing healthcare. Previously, any of the IT systems were always looked as an expense. Today, it is being looked at as an investment. People are going to embrace it for multiple reasons. Part of it is trust on you. Part of it is because you need it when you're talking of data mobility and data portability, which is designed, which is asked for by the consumer. The social revolution is putting a lot more pressure on the hospitals in terms of digitizing their own operations. So that itself will sort of force you to come and embrace digital, by which the health stack, for example, that the India team is working on, is something that is mandated by the government, not only in terms of EMR, but also in terms of the records that go into an EMR and the manner in which it ought to be filled up. So there is a certain pressure. Interoperability and importability of data is going to mandate adoption of digital techniques. And even in India, there are enough and more locally homegrown systems that are available. Are they the best? The answer is not. But does it do the job for India?
Just end with 2 stories. Mr. Ravi mentioned the Apple Watch for detecting atrial fibrillation. Where a lady found her heart rate to be more than what it should be and went to the doctor, found she was pregnant. And the second was a tumor in a child which was producing a catecholamine. And this child also had a very high heart rate. And when they went and checked out, it was a tumor in the appendix which was producing a catecholamine. So both these were incidental diagnosis based on a signal given by the Apple Watch.
In fact, doctor, if I can take 30 seconds more here, like for example, you now will be having cars which will pick up your ECG. And if the ECG is abnormal, it will force you to park your car on the side and call an ambulance to sort of help you out.
Thank you, sir. Thank you.
Life, it's left to imagination now. And once again, thank you, Dr. Manjula and the entire team. Thank Dr. Jagdish for giving me this opportunity. Much appreciated.
Thank you, sir. So thank you very much, Ravi sir. It was really wonderful listening to you, and I'm sure all the delegates have enjoyed your talk as much as we did. And definitely, we would like to learn more about it in the due course. And Dr. Jagdish Channappa sir, thank you to you. Last time, I know I requested you last time to chair the session because Dr. Chandrasekhar sir was not able to join. Thank you so much for accepting it, sir. And we move to the last session. I know Dr. Vidya ma'am, I know I apologize. It's very late for you. She's joining from US. So I request Dr. Bhaskar Shanai sir to come over and then kindly introduce our speaker, Dr. Vidya Sundaresh.
Yeah.
Over to Bhaskar Shanai sir.
Yeah. Good evening. Thank you, Dr. Manjula and team for giving this opportunity. In fact, the infectious disease emergencies are very common, both for pediatricians and for the general practitioners and even the physicians, and more so with the pediatrician. And most of them are, it can affect any system. It can be respiratory or CNS or any system. In the of AMR, we have a lot of infection, bug-related emergencies also. Some resistant bugs can cause emergencies. So unless we diagnose them early and treat them early, if you do it, the ultimate aim and goal will be much better, both in the terms of mortality and morbidity. And to speak about this a very important session, I invite Sundarshan. Incidentally, the very nice thing about her is that she did her undergraduation in medicine from B.R. Ambedkar Medical College, Bangalore. Presently, she is a professor of clinical medicine and chief of fellowship program at the Southern Illinois School of Medicine. She's done a fellowship in infectious disease from University of Kentucky, and she's the medical advisor for the public system. She's the governor of Southern chapter of American College of Physicians. She has got fellowship from both American College and Infectious Disease Society of America. So over to Dr. Vidya Sundaresan for the session.
Thank you so very much for that kind introduction. And I really thank the organizers for inviting me to talk about a subject that I'm passionate about. I have really enjoyed the previous speakers with a visionary approach to population health sciences and infections and diseases that we deal with at the population level. So I am going to redirect you now to more individualized care and talk about the infections and emergencies and infections. I am, in fact, unable to share my slides. I was wondering if, thank you. There you go. So I am going to be talking briefly about CNS infections, airway infections, septicemia, a fever with a rash, and infection in special populations, neutropenic patients, immunocompromised patients, AIDS, returning travelers. I have a lot of slides, but I'm going to breeze through this because I have only 20 minutes to speak. Important concepts really here are, infectious diseases and how they manifest depends on the ecological trial. We have triad, we have the host factors, we have the environmental factors, and then we also have the pathological factors of the organisms that cause the infections. And how they interact really depends on how the disease manifests. So again, respect to the ecological triad and really acknowledging it helps us definitely deal with these diseases a lot better. Rapid initiation of antibiotic therapy and also rapidly stopping when it's not necessary. So those are critical determinants of survival in patients. And then other than that, other than just starting and stopping antibiotic therapy, it's also important to control the source. So those two things are very important when we manage infections. Again, the balance here between infectious agents and host defenses, toxins, virulence factors are some of the mechanisms by which these infectious agents can act, and host defenses can be natural barriers, humoral or cell-mediated immunity. And how we manage them, are we able to get support in a timely fashion, start the correct antibiotics, the drug-bug combination, the correct doses. So now we are really looking at team-based approaches, not just the physician who will be at the helm of these teams, but also pharmacists helping out with the correct doses, correct antibiotic choices. So the team-based approach, nurses who are in a very timely fashion administering these medications, all this comes under the management aspect. And then the host factors, when we are looking at what to give, how to give, also depends on what their past medical history includes. Diabetic patients, patients who are immunocompromised due to any reason, cancer, asplenia. The antibiotic choices can vary based on the type of immunosuppression as well. So coming to a central nervous system emergency, I'll illustrate these with some of the cases that we have seen. This is a 23-year-old lady that came in with a headache and sore throat, had petechial lesions that progressed over 5 to 10 hours, very, very fast progression. She needed emergency intubation, but despite the best efforts, the patient expired the following day. There was a petechial rash. This is not from the patient, but very similar. We didn't even really have time to take pictures with the rate of progression was so rapid. And then subconjunctival hemorrhages. And then when the CSF culture was done, we ended up seeing these gram-negative diplococci on the gram stain that were intracellular. And a lot of them are surrounded by inflammatory cells, these kidney vein gram-shaped, gram-negative diplococci that were seen. So that was meningococcus. The patient had Neisseria meningitidis, which rapidly progressed. Within a few hours, in fact, she deteriorated. And then despite the antibiotic therapy, we were not able to save the patient because she came in about 3 days after she started having some prodromes, and the recognition, although rapid, it's still, you have to rule out the other possibilities as well. We were unable to save this patient. With such illnesses, rapid antibiotic administration is of foremost importance. Of course, these patients should be managed in the ICU with the ABCs first, and then antibiotics should be part of that A as well. Every hour delay in administering antibiotics increases the mortality by 6 to 7%. So some of the petechial rashes that you can see, which can be a telltale sign, DIC, and this rash with hemorrhagic skin necrosis and intravascular thrombosis seen with purpura fulminans can be some telltale signs. Meningitis, whether it's community acquired or nosocomial, requires prompt attention. When it is nosocomial, we see that in patients who have shunts And the choice of antibiotics become different at this point. With a nosocomial infection, we always try to look for Pseudomonas and gram negatives. And if your antibiogram recognizes the presence of really drug-resistant gram-negative organisms, then you should think big and start broad spectrum 2 cover for those till you have the actual susceptibilities from the patient. But for community-acquired infections, strep pneumonia, Haemophilus influenza, Neisseria, Listeria in the extremes of ages are important. But all said and done, after the LP, which shows hypoglycorrhea, high protein cell counts consistent with bacterial infections, antibiotics should not be delayed. In fact, antibiotics should be started in all these meningitis patients. You can stop them quickly once you have the LP, but do not delay antibiotic therapy. So other considerations in patients with meningitis: droplet precaution. So infection prevention is very important in these patients as well. So it can be spread via droplets. So you want to make sure that droplet precautions are instituted unless a treatment has been administered for 48 hours for patients with suspected Neisseria infections. Once that is ruled out, the droplet precautions can be discontinued. And once the treatment has been administered for 48 hours, the droplet precautions can be discontinued. Household contacts and anybody that has intubated the patient, as people who have had close contacts with the respiratory secretions, should be offered chemoprophylaxis. Rifampin, ciprofloxacin, and ceftriaxone intramuscularly are choices. So with that patient, her husband, and the physician who had intubated, the respiratory therapist who had helped with the intubation, all those people ended up getting chemoprophylaxis. Again, a plug for vaccination. We do have the meningococcal vaccines for children, adolescents. ACIP, the Advisory Committee for Immunization Practices through CDC, recommends this for adolescents 11 to 12 years with a booster at age 16. And we are really actually now pursuing this in a big way to make sure that all the college-going children, because this is again a big risk for students that are living in dormitories. So this is a big push now for getting the meningococcal vaccines. And meninge B with the B serotypes is also now part of the routine vaccination for children and adolescents as well. Shifting gears, necrotizing infections. This is again a 70-year-old lady that I saw with small bowel obstruction who was admitted for an exploratory laparotomy. So this was a predominantly surgical case in the surgical ICU. They were managing the patient and she was noted to be persistently hypotensive, requiring high dose of pressors. Needless to say, all her extremities were turning color to purple with this consistent requirement of pressors. She had fevers off and on, but none of the cultures were positive because antibiotics were being sprinkled here and there. Every time the patient had fever, some antibiotics were given and then stopped. The pressor requirement continued to increase. And on the postoperative day 7, they started to note an area of necrosis on the abdomen. And then they took her to the OR and was opened up again. And she had Melanese gangrene postoperative necrotizing fasciitis. So a fever with painful spreading soft tissue infections should alert for necrotizing infections, necrotizing fasciitis, gas gangrene requiring a special mention there. So the superficial fascia, subcutaneous fat, deep fascia, all these are involved. Necrosis of the vasculature as well as nerves in the subcutaneous fat occurs with gangrene. Fournier's gangrene specifically, we're seeing that with the perineum, female perineum, male genitalia, necrotizing fasciitis of that has a name of its own, Fournier's gangrene. And this can affect people who are immunocompetent as well, but typically diabetes, with people with peripheral vascular diseases, alcohol abuse, IV drug use, cirrhosis, and immunocompromised hosts do have a higher predilection for this. Necrotizing fasciitis type 1 versus type 2 versus type 3. Type 1, typically polymicrobial. You would expect type 2 to be polymicrobial, more than one organism, but type 1 is the polymicrobial with a lot of anaerobes in that infection. Type 2 is typically a single organism causing that. Most common is strep pyogenes or group A strep. And you can see that because methicillin resistant Staph aureus is now becoming so rampant. So you can see that in combination with the strep pyogenes or group A strep. You can see that with Vibrio vulnificus in specific hosts, liver diseases, exposure to fresh water. Those patients, you should think of Vibrio vulnificus. And then, healthy patients without obvious portal of entries can also present with this. And the shocking thing is a lot of them, about 50% of them are this toxin mediated illness from group A strep can lead to toxic shock syndrome. Type 3 is the gas gangrene or clostridial myonecrosis. You don't typically see or may not see that crepitus in the typical explanation and the typical description that you see with gas gangrene. You don't see that in type 1 and 2 all the time. But with Clostridium, you do end up seeing that the way we describe necrotizing fasciitis as a crepitus and the skin margins poorly defined, rapid spread, you will see that with gas gangrene. With a type 1, type 2, lab findings can give you a clue, but really it's pain out of proportion to clinical exam that should alert you to think about this. We do get CT scans up front, which help us. Our surgical colleagues, in fact, make that clinical diagnosis. They discourage us from getting CT scans or any imaging studies. The biggest thing for infectious diseases physicians at this point, this is a consultation that I will go in to see in the middle of the night. I want to make sure I'm not missing anything. And most importantly, at this point, I want to make sure I alert my surgical colleagues. So in addition to starting antibiotics at the right time, this is a condition where you have to get surgery involved really early as well. So urgent surgical consultation for debridements. And for type 1, empiric or presumptive coverage with broad spectrum antibiotics to include anaerobes, definitely include anaerobic coverage. You think about cellulitis, and a lot of times you want to think of staph and strep, and you don't usually include anaerobic coverage. But when a necrotizing fasciitis is suspected, definitely anaerobic coverage should be included. And there is a role for clindamycin. Clindamycin inhibits toxins. So along with a beta-lactam, if you're thinking to cover for group A strep, along with group A strep coverage, clindamycin is very, very useful for toxin inhibition. So that is an integral part of our patients that are suspected to have necrotizing fasciitis. We do initiate IV clindamycin in them. And if left untreated, this is generally fatal. The skin can look like this at presentation. It should not be missed. Definitely warrants broad spectrum antibiotics and a surgical consultation in presentations like that. Clostridial myonecrosis, fulminant clostridial infections of skeletal muscles, very high mortality. Clostridium perfringens is the usual perpetrator there. Clostridium septicum, association with cancer specifically, abdominal source, that can actually cause clostridial myonecrosis in patients who are immunocompromised with cancers. But usual perpetrator for clostridial myonecrosis is Clostridium perfringens. This was one of the patients that we had seen, and you can see that that skin where the necrosis is occurring with the toxin rapidly spreading, you can almost see that demarcation in the skin. And then you will see that if an imaging study is done, there is gas in the tissue that can be telltale for this. I want to quickly talk about animal bites. As pets are a big part of many people's lives. Capnocytophaga canimoris, especially in patients with asplenia, can lead to overwhelming sepsis. Only 1% of the ED visits could be from animal bites, but a type of animal, circumstances of attack, timing of the bite, location of the bite, all these should be taken into consideration when a history is taken. With a physical examination, evaluate for purulence, necrosis, edema, extent of the injury, and a neurovascular compromise. And again, the wound needs to be taken care of, any foreign body that's there that needs to be removed. So source control is very, very important. So surgical consultation is important in this case as well. A lot of the antibiotics for animal bites, we treat with amoxicillin clavulanate. If there is a penicillin allergy, the alternates can be doxycycline, ciprofloxacin plus metronidazole, or trimethoprim sulfa plus metronidazole. Human bites, when there is an intentional bite or a clenched fist injury, mostly associated with oral flora, Eikenella, Haemophilus, Fusobacterium species, Prevotella, a lot of the anaerobes, we really need to cover for them. And in addition, with human bites, you also want to initiate HIV, a post-exposure prophylaxis in case there is a risk. So that needs to be done as soon as possible, ideally within 72 hours. But post-exposure prophylaxis for HIV, there is a role for bloodborne pathogens there. Hepatitis C, there's not much we can do, but serially, these tests have to be done to ensure that there is no seroconversion for hepatitis C or hepatitis B. Following the rule of 3, 30% chance for hepatitis B transmission, 3% for hepatitis C, 0.3% for HIV as a bloodborne pathogen. Augmentin or amoxicillin clavulanate is again good for prophylaxis. The third group here would be airway or neck space infections, depending on which neck space we are dealing with, anterior, middle, or posterior. We need to think of the complications. This is a case of a 65-year-old gentleman with hypertension that came to the emergency room with a 3-day history of sore throat, dysphagia, and chest pain. And his exam showed he was initially afebrile, neck was supple without any visible masses. But then he comes back the next day with drooling and inability to clear his secretions. White count was extremely high at 41,000, with predominantly PMNs, 26,000 segmented neutrophils, and bandemia. So here you see the CT scan showing a large abscess and gas in the mediastinum. And then he was taken to surgery right away, retropharyngeal abscess with extension into the pretracheal area was noted. So depending on which space it is, if it is the anterior mediastinum, you expect that to anterior neck space. A lot of those enter into the mediastinal space and cause infections. And with the posterior neck abscesses, there's also a chance of metastasis to the brain. So depending on which neck space it is, we really need to evaluate. Lemierre's disease, where you see thrombosis in the jugular vein, can be associated as well. Decisions for whether they need surgery or if you need to initiate any anticoagulation in such patients. Again, those are complications that you can see with neck space abscesses or neck space infections, and these should be dealt with emergently. They're compromising the airway, especially, so these have to be dealt with as soon as possible. And most of the times you see group A, group B strep, anaerobic species, oral organisms. So pseudomonal coverage is not really necessary. Beta-lactams, and if there is an allergy to beta-lactams, again, even with allergies, you want to make sure that it's a true allergy. Here, penicillin allergy is really overrated. Almost every time on the chart you see penicillin allergy, it would be, my mother told me not to take penicillin, so I'm not taking it. So we are losing a really good group of drugs because of that penicillin allergy. So that would be something to caution and look at. A bedside penicillin skin test is available, very easy to administer. Within half an hour, you get to know if it's a true allergy or not. So we use that a lot to determine if that can be given. And one more thing I'd like to mention is if somebody is allergic to penicillin, you can still go with a cephalosporin or a carbapenem. We try to avoid carbapenem sparing as much as possible, but cephalosporins are a good group, along with a good anaerobic coverage. Fourth generations don't really have anaerobic coverage, so you will have to use another medication for anaerobic coverage in addition there. So treatment, extensive exploration, debridement, and then starting broad spectrum antibiotics definitely is not wrong in this case, and then starting an aggressive surgical management. This was a case of epiglottitis. Patient presented with stridor, febrile, very toxic looking, could not lie down, anterior neck pain, drooling, or dinophagia. And then examination, when you suspect this, you really don't want to do a big airway examination. That in itself can trigger stridor. So control the airway, start antibiotics right away. Haemophilus is the offending pathogen most of the times. So third generation cephalosporin, macrolide does really well for this. Sepsis, pet peeve, a 79-year-old male here coming through the emergency room with fevers and cough. This was an April admission, thought to be septic, admitted to the ICU based on the vital signs and the initial labs, stabilized in the ICU. And then after a few days, his platelet count started to plummet, and he noted all these necrotic infections. Actually, this was a patient I saw in my training, and I took a picture with a primitive cell phone those days. And you can see the lesions actually starting to clear. This was purpura fulminans in this gentleman. We realized he didn't have a spleen. Blood cultures at that point were repeated. All cultures were taken. And then his cultures came back with strep pneumo. So in elderly patients, strep pneumo is something that you really need to treat very, very quickly. They can deteriorate very fast. Typically for sepsis, gram-negative sepsis, patients do really poorly. If you start antibiotics, they recover faster. For strep pneumo, you see more with elderly people. Their recovery can take some time for the gram positives. So correct antibiotics, correct diagnosis, and then their support in the ICU is very, very important in these patients who are extremely sick. And also a plug for vaccination, strep pneumo vaccination. ACIP has now, in fact, come up with updated guidelines. We have a conjugate, very effective conjugate vaccine with higher and higher and higher valence. So 20 valent, and I'm pretty sure we're going to go up even more on the valency for strep pneumo to include more of the antigens, and they are very effective. So even in children as well as adults, this should be something. With adult immunization, we don't push as much, but these are very effective and in decreasing mortality, in decreasing invasive disease. So again, a plug for vaccination for strep pneumonia there. This patient was switched to ceftriaxone after broad spectrum antibiotics, and then after 2 weeks of antibiotics, he actually recovered pretty well despite his advanced stage. Sepsis, head to toe manifestation has to be recognized. Altered mental status, a lot of times our ICU consults are in sepsis patients with altered mental status. In fact, if you are calculating a SOFA score, the sequential organ failure assessment score, in fact, that is one of the things that you can identify on the floor when somebody presents with altered mental status and have sepsis on your list of differential diagnosis. But a lot of the times, our ICU colleagues call us for altered mental status in a septic patient. To do an LP or not can be confusing, but history and physical, which is really what a lot of the cognitive specialties like us in infectious diseases do, the chronology can really help out making these decisions for high value care, avoiding unnecessary tests, high value care. So that's something that we need to keep in mind as well, in addition to starting antibiotics and stopping if it's not necessary. So with sepsis, one thing I would say is cultures need to be obtained before the antibiotics are initiated. And that will definitely improve the yield. And imaging studies, again, keep in mind, you really want to make sure you don't want to get unnecessary antibiotics. I'd mentioned this in the first case as well. So starting IV therapy, antibiotic therapy within the first hour of recognition of severe sepsis And after obtaining appropriate cultures, every hour delay increases mortality. So starting antibiotics, and again, based on what you think may be the source, you can think of coverage. So if it's the abdominal source, you think of anaerobes, you want to cover for gram negatives. Recently, with the Infectious Diseases Society meeting, there was a discussion on whether or not we should cover for enterococcus and fungus, presumptively. Probably not. If you've got gram negatives, you've got anaerobes, you're good. For intra-abdominal infections, if you're thinking it's a pulmonary source, is it community acquired? Is it hospital acquired? All those should help direct the antibiotic therapy. But start broad, and while you are de-escalating, evaluate your cultures day 0, day 3, day 7, day 10. By day 10, your antibiotic should have a course, should have a future of whether to be continued or not. You should know what to do. Beyond that, it's not very useful to continue broad spectrum antibiotics. Neutropenic fever, again, another emergency here. These patients are sick. They can deteriorate quite fast. So they meet the criteria. Is it sepsis, not sepsis? There's always that argument there. I would just say one thing. For neutropenic fevers, nobody is going to fault us for starting broad spectrum and leaving that broad spectrum antibiotic for a longer duration. That's one condition, because a lot of those cultures are not helpful. They don't come back positive. So we start off with gram-negative coverage. That's most common. So pseudomonal coverage, definitely start out with that. There are port involvement, and you suspect a port infection, add a gram-positive coverage. And with severe neutropenia and immunosuppression, think about fungal coverage. These patients do have a high degree of fungal infections. They are immunocompromised, so fungal coverage should be, you should have a lower threshold for initiating those. And viral infections, the reactivation of viral infections, HSV, and those can be treated with short term as well. So, and specific timelines for organ transplants, that should be kind of kept in mind here. If it's an acute or a chronic phase after organ transplantation, immediately after the transplantation, you think about nosocomial infections. After about 45 days of transplantation, you think about organisms like CMV, Aspergillus, and then later on, Aspergillus persists there, varicella zoster, encapsulated organisms, encapsulated bacteria, pneumocystis, all those kind of come after day 100. So the timeline is very important for patients with hematological cancers and hematological transplants, as well as solid organ transplants. And a special mention to the fungal infections here, invasive aspergillosis. You can have some signs there radiologically, a halo or a ring sign. A radiologist can help us identify that. Here, not very good tests other than some antigen tests, which take a long time to come back. You don't want to hold treatment. You want to start treatment early. And you can stop that when the tests come back negative. So voriconazole, isuvaconazole, newer azole, all these are good for treatment. Amphotericin B, a lot of physicians are scared to use amphotericin B upfront, but these sick patients, you can do a lot of benefit for them than damage. And if used properly, along with our pharmacy colleagues helping pre-treatment and watching very carefully potassium, magnesium, creatinine, I think those things are really helpful with careful supervision. Fusarium is another fungus that we see here in these neutropenic patients who are extremely sick with hematological cancers, skin manifestations there. It is a mold just like aspergillus in tissues, but you can see these tender red spots like you're seeing in that picture there. And if blood cultures can be positive. In fact, that's a little different from aspergillus. 1/3 to a half of the blood cultures can be positive. Again, amphotericin B is effective in treating these patients. If they have any hardware needs to be changed out. This is one time where we are really sticklers about removing that hardware port or any access. With fungal infections, we do, and bloodstream infections, we do insist. Primary influenza, infections can be avoided with a very effective vaccine, even if the efficacy is not that great. What it does is it definitely decreases the severity of illness. It decreases the chance of hospitalization by almost 80%. That's a big deal. So you really want to make sure that patients who are immunocompromised are up to date with influenza vaccines. You want to avoid the live virus vaccines there, or you definitely can give them any of the quadrivalent vaccines, the recombinant vaccines if they have egg allergy. Mucor took on a new respect when we saw that increase with COVID and the post-COVID era. But diabetics coming in with this discolorated skin and Mucor should be high up on the differential. That's a special population. Again, a surgery needs to be initiated, and you want to start the antifungals, azoles or amphotericin B. I'm sorry, azoles there. Candida in the ICU setting, you see a lot of Candida. Candida glabrata is the is the kind of a resistant Candida where fluconazole will not work. Echinocandins are good choices for patients in the ICU because they have fewer drug-drug interactions, and they're tolerated better in the ICU also because of the possibility of the resistant fungus, Candida glabrata. So in ICU patients, in immunocompromised patients, Candida is never a contaminant in the blood. When you find it in the blood, it has to be treated. 50% mortality if it's not identified properly and if it's not treated properly. In fact, a lot of times we get these curbside consults when you're walking and somebody will just ask you, doctor, do you want to be consulted on this patient? I just found Candida in the blood. This is Candida. You think it's a contaminant? I jump on that and I say, please, I will see this patient right now. Take me to the patient. So those are the kind of patients that you really want to get on the case and treat appropriately. Candida endophthalmitis. MD Anderson did this, when catheters were pulled and they found Candida, they did not treat a lot of those patients. A lot of them ended up having endophthalmitis. So we try to involve our ophthalmology colleagues as well, because as ID, we cannot make specific diagnosis as to which part is it, retina or uveitis, what exactly is going on. They help us with that specific diagnosis, which will help us treat the patient optimally with the correct antifungals. So with Candida infections, very important. And a CGD, another group, we don't see this much as an adult diagnosis, but in pediatrics, this becomes very important. Staph aureus, serratia, Burkholderia, nocardia, these are some organisms which are specifically seen in patients with CGD in the pediatric population. With the diagnosis of CGD, you need to have a higher level of suspicion for these specific infections. Infections with biologics, again, you should have a higher degree of suspicion for tuberculosis. Here in India, definitely, because you see a lot more high prevalence country. For us, a lot of the times the quantiferon is performed. If it's positive, they're treated before starting biologics. So that's part of the routine in treatment there. So the practice is a little bit different in low prevalence areas. But with high prevalence, these infections and reactivation infections, fungal infections, you want to definitely be careful. JAK2 inhibitors are used with COVID. We actually saw a lot of rare organisms like Burkholderia, Stenotrophomonas, fungal infections post-treatment in COVID in the ICU with high-dose steroids. We're seeing a lot of, in the place where I'm from, we're endemic for histoplasma. We did end up seeing a lot of those endemic infections there as well. Quick word about infections in HIV. Opportunistic infections, pneumocystis, toxo, MAC infections, all these require a high degree of suspicion based on the CD4 count. But pneumocystis, although in an immunocompromised host, you see a subacute presentation. When identified, that needs to be treated. Patients can deteriorate. If their infection is severe, they can be in the ICU, so need to have a high degree of suspicion in HIV patients with low CD4 cell count. Cryptococcus is in fact now going up again. Cryptococcal meningitis, we had an epidemic when I was training. I every HIV patient that was admitted, every second or third patient I saw had cryptococcal meningitis, disseminated disease. Now, later on, it started to come down. For some reason, we are kind of seeing a spike now again in cryptococcus. So those are some of the infections that you need to watch out for in patients in HIV. Returning travelers world over, so not just important to know what's happening where you live, but the world is now shrinking with travel. So travelers are really exposed to a variety of hazards by virtue of travel, and spot diagnosis, fever and rash. I saw a patient yesterday who had just come back from Uganda, and really history helps so much to see what the next steps need to be. So this was a patient who had traveled to Uganda, but went to Kampala, where there are 10 cases. But the other areas this patient went to were not high risk. So we were just comfortable monitoring him at home, but for the 21 days of incubation. But again, cutaneous larva migrants, these can be subacute diagnosis, but fever in a traveler, returning traveler, typhoid fever, malaria, and falciparum, cerebral malaria, those are emergencies, and those need to be addressed very, very promptly. Ebola, like I was mentioning, this was a 36-year-old missionary that came back. This was not now, but in the past, in 2014, came back from Sierra Leone and presented with GI symptoms, vomiting for 2 days and fever for 3 days. Notice this very telltale blister, was feeling unwell, presented to the ER. So that was Ebola. So Uganda's now, maintaining the surveillance. There's about 130 cases this year. So patients that are coming from that area, if they have been in a high prevalence or where cases are found in Uganda, you need to have a high degree of suspicion. Fever with rash, the differential can be pretty high depending on where you live. Actually, in travelers, rickettsial diseases and then parasitic infections are common, but then if you see a patient with rash in the ICU, DIC, you want to rule that out. You want to see which infections actually cause those skin manifestations, like the previous slides I showed you. Is it a drug reaction? So all this needs to be ruled out. And then these are some examples of a Rocky Mountain spotted fever. Your wrists and ankles will have that typical rash, dengue hemorrhagic fever. I will be preaching to the choir if I talk about that, but the diagnosis there with the petechial rash as well, with diagnosed with the BP cuff. So COVID in the post-COVID era or post-emergency phase of the COVID era, severe COVID can still be a problem. We're still seeing patients, in fact, now with the BA 1.1, there were, in fact, people who have not received the booster, the bivalent booster yet. We are still seeing that, but definitely not as much as what we were. The deaths in the US have come down from nearly 3,600 a day to about 300 or so. So a reduction with the vaccination, and the previous talk we heard, the fantastic talk we heard, illustrates how vaccinations have helped us. So still a possibility, thrombosis. We are admitting patients with PE, strokes, MI, post-COVID. There are patients with myopericarditis, long COVID, psychosis. In fact, that can be a reason for admission. Miss C, Miss A, seeing some Miss C still, and then fungal infections can be seen with post-COVID. Last slide here with syndromes and ID, toxic shock. So, there can be multiple system involvement with syndromic presentations. So those can be some clues to what we are dealing with. You may not always find the organism, but the syndrome in itself should be, these clinical syndromes are still very useful in diagnosis. I'll end with a quote from my mentor in infectious diseases, Dr. Nancy Kaduri. The course of human history has been altered frequently by the capability of infectious agents to spread and cross national and international borders. So our scope of knowledge in infectious diseases, as it increases, as our previous speakers have talked about, more of a population-based approach to this. I think that is a great message and something to bear in mind as we treat our patients with emergencies. I will end here and take any questions.
Muted, sir, Bhaskar sir.
So thank you, Dr. Vidya, for that wonderful session. I think these are the need of the hour, wherein we do see a lot of, you have sensitized us for the all the emergencies. Thank you so much. Any questions?
One question to Dr. Vidya after that fantastic talk. Dr. Vidya, now in India, we don't monitor levels of antibiotics other than aminoglycosides and maybe sometimes vancomycin. Now, I don't know how your system works. Do you monitor the levels, especially in those acute emergency situations where you have problems with blood volume and otherwise?
That's a great question. One of my mentors always says that and we should have drug monitoring for every antibiotic. We don't. Vancomycin now, our pharmacy colleagues are doing something called an AUC by MIC, which is again like our previous speaker, Mr. Ravi had talked about AI. We're using technology to monitor those levels. Because when we were looking at how vancomycin levels were monitored, you can see how we have changed our practice from a trough of 5 to 10, which was considered therapeutic, to now 15 to 20. So that requires higher doses and the side effects, nephrotoxicity, and you see even bone marrow complications from high dose vancomycin that we give, people actually losing their hearing from vancomycin. So we want to avoid those high doses and still get the benefits. So pharmacy now uses a modeling called AUC, area under the curve divided by the minimum inhibitory concentration there. And they're able to tell us, and we are using lower doses of vancomycin, and definitely that's beneficial. So yeah, we don't monitor everything. It can be tricky, especially with drug-drug interactions, and also the use of bacteriostatic versus bactericidal drugs. There's a lot of new information now coming out, and the shift really going from aggressive IV antibiotics to oral antibiotics. So I think that would be something to look for in the future, levels of antibiotics, which would be a very useful tool for us to monitor.
Thank you.
Thank you very much. I think there are no further questions. We'll close this session. So thank you once again, Dr. Vidya, for joining and enlightening us. Thank you, Fever Foundation, for giving us the opportunity.
Thank you so much.
Thank you very much.
Thank you, Dr. Vidya. It was very kind of you to join, though it's little odd hour for you. And Dr. Bhaskar Shanai, thank you so much coming, and I know you're midst of some other session. Thank you so much for joining in, sir.
Thank you, sir.
Yeah,
Thank you.
Dr. Jagdish, sir, that was the last session for today. I think with Dr. Bhaskar Shanai, you and our other advisory members, Dr. Anupam Prakash, and Dr. Narsimhalu sir is there, Dr. Nagraj sir is there, Dr. Ramesh is there. So can we close today's session, sir?
Yeah. Yes.
Right. Okay. Thank you very much.
Thank you very much, everybody.
Thank you.
Sir. Thank you very much.
So,
Thank you,
RX
Dr.
event,
Vidya,
can
for
you
this.
have the closing session video, please?
A very good evening to one and all. I'm hoping that you had a wonderful day one with so many learnings and so many takeaways, going back home with a fun-filled, knowledge-filled day. Well, the day 2 of FeFCon 2022 will begin at 9 a.m. and the first topic of the session will be Know Your Antibiotics. Good night and please take care.
So can we stop the recording, please?
Recording stopped.